nuia, tai au fia, whaatai lea lofa o lea tua. O tātou au lia mai le nei tai au. O le aso muli fo'i o le wha moe a le Medicaid. Ia o tau pa ia ma o tau mamalu o le ale o iai se whamtalanga. Sau se teimi muli ane. Ama sau noa lea o le wha tonu e anga tonu ai le tau a fio mai. Ai tau na o wha pia atu tā alofa lava. Ia. Tātou te mua lava na Silvi inga man whaftai le atua. Ia le mea lea o te wala au whapito atu i le sunga ia le tuu. Le tuu, whamole se saunia se talo a mata. Se I kikia ne ai lalo le background o le pese lea whamole lava. Can you turn the music down, please, Carlos?
Talo, sanga via lava pea lau fio le nei tular tai au, ia o matua la whai mai nei tai au, ia o folinga pea lau fio, o le vi inga lava tu mau tu lau fio nei se ia o le whagavau. Whaftai le ola malmalosi o e foina ia te matua lau whanau, ia wā foi ia tiute ma whaiva o lo whea ngai ei. Ia nisi foi o whanau o lo whea ngai ma o onga. Ia misi foi nei o matua o lo whaia le whaiva o tapua i le atua matua tamau. Wai sila fia le whamoe nei aso. Ia au mai ni manatu lei, ia whaasoa i pea, ia wale alua luma o mato atunu le atua mato tama, whatasi mela o fio le whamoe nei aso, mua au muri au mea uma mato te whaia. Ia e fo e toi pelvi inga lau fio, o mato talo lea ala tulo soaf pelo Yesu Kiriso. Amen.
Whaftai lava le tuu, whamanuia le atua ia te oe, ma lau tofi fōu nā wa iai. Yeah. Today's presentations, we're going to focus on health information technology and the financial part of the Medicaid. So, but before we move towards the presentations, I understand some of you were not here on Monday and Tuesday. Yeah, and some of you have been with us since day one. But before we go on, we would like to reintroduce the staff once again, just so that you can put a name to a face when you come to the office or you call us, you know, for assistance. So I'd like to call upon Austin. Sumailunga sa ikoe introduce ako kako staff, amolmole. Manino, do I have the clicker? So we have the QR codes on here, and they're also on your tables. If you want to get access to the agenda, our resources, and there will be also a
QR code for the question and answer.
For the questionnaire at the end. Thank you, Austin. Okay, so as you all know, my name is Failangi Pofa Faiai. I am the Deputy Director and also overseeing our Policy and Planning Division.
And my name is Austin Asiata, and I head the Benefits and Eligibility Division. Introducing our new Medicaid Director, that is Mrs. Luisa Lealai Suesuekwaya. And our Administrative Division is headed by Philip Yosefo.
Philip, please stand to be recognized.
Philip heads the team of 3, Beverly Liu Tufuli as the Senior Administrative Assistant, Gideon Mapusanga Jr. as the Admin Assistant, and lastly, Admin Assistant Wesley Besse.
And this is our administrative team. They are the backbone or provide support to all the divisions within Medicaid.
Moving on to our finance division, one of the most important divisions in the Medicaid office. They handle everything from paying our bills, getting us paid, and making sure that everything is compliant, our local match is in order, as well as drawing down the funds. Everything is compliant with CMS regulations. And this division is headed by Epifania Yosefo Salofa, who is currently not here with us, but we wish her well. Next, our staff accountant and acting finance division head, Mrs. Wilhelmina Sailua Tongafao, and she will be presenting later on today. Lastly, Nemo Mangel Salavea, she is our accounting technician.
At wain to pemeni ya olvaenga le suatu ai.
The Benefits and Eligibility Division, this is the division where we handle all referral services from DMEs to off-island Medicaid referrals to vision benefits. And our benefits and eligibility coordinators are as follows. Mrs. Diane S. Leomiti, she has served in this agency for over 20 plus years.
And ASG altogether for more than 30 years.
Letu'u Alei Lesulu is our benefits and eligibility coordinator as well. And lastly, Cora Talawenga, our other benefits coordinator. Oh, sorry. And lastly, for the benefits and eligibility division is Jennifer Ngatayela Sua. She is our Hawaii patient navigator.
Yeah, oh, this is Matilda A. Cruz. She heads our program integrity division, AKA our police department, our compliance officer, our everything. So this is the person you would want to file a complaint with if you are not satisfied with the services.
Policy and Planning Division, our Informatics Policy Analyst and Acting IT Division Head, who will also be presenting today, is none other than Jeremiah Salah Fale. Our Policy and Planning Division, we also have Manina Oilau Iseula Reed, our Public Relations Officer. And finally, we have the undeniable Dr. Annie Fuabai, who is our Clinical Medical Director.
Dr. Annie plays a critical role in our off-island referral services as she reviews your referral when we receive them. So be nice to Dr. Annie. Okay, so that concludes the introductions of our staff. We are now going to move into our presentations. The first presenter will be Mr. Jeremiah Salah Fale, and he will be presenting on health information technology. Please, Jeremiah, Sumai.
Good morning, everyone. Tao manuia, lange mama, male soifo mo alini tao, tato umo lo o whanga potu mai, o lo ingo Jeremiah Salah Fale. I've been with Medicaid for 2 years now. It has been an honor and pleasure to work alongside with all our other employees, especially our new director, our firm director, deputy director, and everyone who are part of the agency. It is also an honor to be in front of you all today to share, collaborate with our agencies, our stakeholders, as we proceed forward day by day with our workflow and ways to also to find solutions to better our healthcare system in American Samoa. So today, I'm gladly here to present to you one of the division in our Medicaid organization, which is the Health Information Technology. Just like our Program Integrity Division, there's only one of us each in our division. And as mentioned 2 days ago of our summit, we're looking into expanding these divisions into more people as we also are thriving to expand our services to the community and especially the people of American Samoa. Feel free to stop me if you have any questions. If not, there is a last slide to share and collaborate your thoughts and your ideas as we move forward. So our division's thriving motto is transforming ideas, streamlining processes into digital reality. In American Samoa, I solely believe that we're still in the system of pen and paper. Everything is conducted manually. Sad to say that I think majority of our government agencies are going through the same process. We still haven't adopted the new 21st century system. And there could be a lot of contributing factors to this reason. With Medicaid, we are thriving forward to procure and secure an eligibility and enrollment system, as well as our MMIS, which is our Medicaid information system. One of the factors that has been the delayed reason for all these systems to be in place, it's because of our funding. And we all know the healthcare system in the United States, it's very, very legit, very durable, and very straight to the point. Here, we are still processing everything manually. Oh, can I get your ID? Let me make a photocopy of your ID. Let me write down your name. Can I get your last name? Where are you from? What's your agency, department? What's your SSN? All these different information are being taken down manually on paper and pen. And that is our thriving motto this year as we move forward, as the Medicaid move forward, is to transform and streamline all the processes into a digital reality. And that is our infrastructure automation. Governor had a press release about the ARPA funding available, we just recently put together with Director a proposal about the infrastructure automation. Yes, we can build. We can infrastructure a lot of buildings here in American Samoa, but what's the use of it? If we cannot automate the information that we currently have in our department and in our agency, we are not moving anywhere. If a doctor from a island requests an information from our local hospital, from our DOH, and we cannot share the data automatically, there's no use of our buildings. There's no use of the services that we do. And that should be the mentality that we have from all our IT point of contact, our IT personnel in each divisions or department or agencies. We have to look forward, to look ahead, to look in the future, to transform anything into infrastructure automation. As you see here, this is the key benefits of our infrastructure automation. It can faster the development operations adoption. It can reduce the cost and complexity. It can be very efficient with the workflow instead of the pen and paper. It can faster time to market, and then it can reduce errors. Our division overview. We are here to provide technical assistance. This is internally, as well as our public. We're here to computerize system development and maintenance for transparent transition of information, share of patient information, and then we're here, we are designed for technical issues. Again, as shared before, that we're looking into expanding our division, and here are some of the things that we're looking into if we do hire some of our technical vacancies within the department. So whatever technical issue that maybe arises within our division, our agency, or between the share of information amongst the department or agencies, for example, LBJ, DOH, or our current service providers, these are some of the things that we look into. Our mission is to secure an authentic system, and that will be our E&E, eligibility and enrollment, and our MMIS. Our vision, we look ahead, we envision an American Samoa automation infrastructure platform. Okay, our current system that we have right now, and we have given access to our service providers that has been shared by our benefits division 2 days ago. It's called QuickBase Database System. This is a commercial off-the-shelf system. Off-the-shelf system meaning a system that's already been developed and has been created. All you need to do as a buyer is to purchase the system. You can customize the system to tailor it to your workflow processes and the ongoing processes within your department or agency. It's been with us for, I believe, 2017. It's a really good internal database system, and this is how all our referrals from LBJ, for DME, for Vision, has been processed between us and also our provider service providers within our network. It can better work with the workflow management, and then it does automations and integration of data. Okay, data analytics. We thrive to improve service available to the community. We improve programmatic decision making. This is where we collect data. We meet with the stakeholders to improve our standardized operations, and all within the different segments. Each agencies like LBJ and DOH, we share information about each patient that may be registered to our for our services. We look into techniques and methodologies to better with the sharing of information to make sure that it's HIPAA compliant. We're here for building and executing statistical models, current trends. This is very important because QuickBase, and just like any other system, it gives the data trends per year or per quarter, however we want to streamline the data processes, just to give an overall outlook of the trends that we have every year, and that can better help us make the decisions that will gauge the improvement of the program. Planning and implementing actionable information, and then we're here to develop transfer protocols. This is information bridging. It's very important, just like I shared before. Everything here is HIPAA compliant and has been shared with Matilda Cruz as part of the program integrity. We really look into protecting our patient health information. Okay, we have some in-progress database system projects that are ongoing right now. Like I've shared before, we have our E&E, eligibility and enrollment system. We have our PABD, advanced planning documents for E&E and MMIS. And then our MMIS, Medicaid Management Information System, and then the visualization tools. So the difference between an E&E eligibility and enrollment system And the MMIS, eligibility and enrollment, is strictly to enroll and to identify, determine the eligibility of a patient. For MMIS, this is tailored specifically to the claims that will be submitted. Also, this is very important. I shared with Matilda Cruz a day ago, if you are a beneficiary in Hawaii, MedQuest, or whatever healthcare plan in Hawaii or in other states, if we do have the MMIS in place, the system can automatically detect that you are a beneficiary somewhere else, which means you are not eligible to claim Medicaid benefits locally. As shared by Matilda, and I'm reiterating that today, if we do have the MMI system in place, the system will automatically determine that you are a beneficiary somewhere else, and you will not be able to claim any Medicaid benefits locally. The PABD Planning Advance Planning Documents, this is a form of document that whatever changes we will make, whatever updates we have been processing this specific document from CMS, we will be able to give the updates of the progress that we made, or the eligibility and enrollment request for proposal by the American Samoa Medicaid State Agency. It will be up for bidding, processed through the NASPO, that is the National Association of State Procurement Officials. The process is straightforward. We just have to send them the RFP. They will go out and present it to all these vendors. Us, we will be part of the process as far as selecting which will be aligned with the budget that we have, and also the services and the workflow processes that we're looking into. So again, it's up with the CMS final approval by Dr. Hong. Once that is done, it'll be up for the bidding process through NASPO. The deadline that has been given to us is the ending of fiscal year 2025, which is September 30th or 31st of this year, 2025. So we're still in the game, a little bit ahead of the game, and that's good news for us. For MMIS, as of now, we're still researching for all the guidelines and the requirements to draft our RFP for Medicaid Management Information System. This is a little bit difficult because it's a system that involves claims and invoices, the financial side of the Medicaid process and all of that. As I shared before, the difference between the two systems, it's very straightforward. It's eligibility enrollment, and then the MMIS. Our deadline for the MMIS system is Q4 of fiscal year 2026, which is next year. So we still got a little bit of cushion to work on this project, but it's always good to start ahead so we can get, there's a lot of reviews and a lot of approvals that'll be done by CMS. Okay, so for our current providers right now, with QuickBase, you cannot access the system just like any other department unless you complete our internal form that'll be granting you the access to our system. Some of you have requested to be on our system. Again, we thrive by HIPAA, so it's not a system where we can just come there and register to get 2 candies or 3 candies. You have to go through our proper protocol, which we have a form here that will be sent out to all our service providers. You have to complete, it'll be reviewed by our IT division, our deputy, and our director in order to grant access to our system. Okay, our website has just went on live. Nino, if you can put on our website. So our website right now has been updated. Please go ahead and navigate through the website. It has all the information that you may inquire about. And also, if you do have any questions, please reach out to our division or any Medicaid employee that will be there to assist you. It also has the forms that you may inquire about for referral, for DME, or for vision. And that's it. I know it's the morning. I'm just giving you the floor for any questions as we proceed forward with our program. Thank you. Do we have any questions on the floor?
We do have a question here, Mr. Mo.
Fatulo watu e fo tatou tala fa Samoa langa fo I tatou tala so ostamak atulo la. I have some comments about again transparency, the use of your management, the technical side. The Fono had or the Senate in particular, had a problem with misinformation, as our people do. You know, they stretch the truth and stuff. So they came up with an idea of, with our technical side, to put in our live feed, and it started with just a few thousand followers, and it's gotten down to 2.6 million. Especially during the sessions, we have a lot of 20,000 people in the States, about 18 in Hawaii, 19 here. So I would ask you to entertain something like that when you have important decisions that you make or nice accomplishments to offset the misinformation that goes around. We all know what information there about, misuse of funds. But if you were to take this and maybe have a live Facebook session when you do these events come up, or YouTube, we're on YouTube all the time. This would help really if you can incorporate this in your transformation. Number two, I wanted to ask you about cybersecurity. Have you encountered anything about cybersecurity? I don't know if Medicaid was involved in that, those funds that were transmitted to LBJ, and now we're having trouble getting it back. But are you handling that situation if you have any cybersecurity involved in your transferring or handling of funds? I think that's all I have. Thank you.
Thank you. Let me just reference to the first part of the question. Again, I believe we all know that every agency, every department sets a different platform for the community. Fono is different from Medicaid. Medicaid is different from LBJ, and so on. With the advice that was given, I do appreciate, and we are working closely with our team to spread out the word, to campaign, to do press conferences about any updates that may be incurred within our department, within our agency, just for public information and to make sure we are all on the same page and for public awareness. The second part of the question was cybersecurity. Medicaid has received about 4.2 million of the Consolidated Appropriation Act, where CMS has allotted for the 5 territories to improve their Medicaid system. And as part of that, we are also considering some of these factors to help us, develop. And as we are trying to procure a MMIS and an E&E system to tailor to what we do internally, as well as the work processes that we do on a daily basis. Thank you.
Just to add on to Jeremiah's statement about having the live feed for communication purposes, the director and myself and some of the team, we were talking about how useful the summit with getting the word out. And in fact, this was the year that Medicaid was focusing on outreach, getting that. Now that we have these services available, we want to go out there and push it out to the public. And as far as communicating, we are working at having a press release or on a monthly basis discussion, like the discussion we had yesterday with our panelists. You know, we want to get that conversation going and at the same time put into action so that we don't want to discuss today and just leave it until the next summit or discuss with Laia. So we're gonna try our best to get that info out.
Thank you, Deputy Maya. And I just wanted to build on the request about cybersecurity. You know, CMS, they set the standards for all of the Medicaid systems in terms of Medicaid systems through their policies like minimum acceptable risk standards, as well as the HIPAA security rule, which requires all Medicaid programs to protect electronic protected health information. But it is up to every state to follow those guidelines. And now that we are pursuing an MMIS, which is a Medicaid Management Information System, as well as an E&E, we are following these guidelines. And so we are hoping that we can partner as well with ASTICA, you know, the network that we are going to be on, and make sure that we are in compliance so that there are no breaches in information or security on the network. So thank you for that question.
I have one more, please. You showed a form of to access your information system in your presentation. Can I, as a investigator advisor for the FONO, do you grant access to your information if I fill out a form so that I can access information that's wanted or desired by the FONO? Or is this only for your service providers? Or
Thank you for the question. This is specifically for our service providers. Until there's a service provider agreement in place, signed by our program integrity, our director, and all those affiliated with the provider service agreement, you are officially a service provider for Medicaid. And that's when this form will come out to you in order for you to access the system. Thank you. Any other questions?
There's a question here.
Sorry, so the question is really looking at the process versus security. If, for example, or not so much of an example, if there is an added model of system into processing an individual's application, would that impact their eligibility? Not sort of impact their eligibility, would that delay a person's application when it goes through an added layer of system that you'll be putting in place in the future?
Sorry, I couldn't hear the question clearly. Can you repeat the question?
So I see that there are projects in place in the future that there will be, I guess if I'm not hearing correct, there's an added system model into when a person goes through the system, when they're applying for medical benefits, would that delay or perhaps, per se, the person's application? Like
No.
For example, there's an there's an E&E, and there's an IMIS added to that
Okay,
process.
thank you. It's clear now. So for the eligibility and enrollment, that is specifically to determine your eligibility inquiry as a beneficiary. The MMIS, it tailors more specifically to the claim. Once the service is rendered, the provider can send over the invoices through the system, and our finance team can extract the information from that system. But it won't delay any application. This will help improve the process right now. So once you put in your application from wherever, from at home or on the road, Austin and the team will go ahead and review your application on this enrollment system, and it'll give you a decision for approval or whatever reason if it gets denied or whatever. Thank you.
Yes. If I may add on to Maya, especially because the question is asked for beneficiaries and enrolling with the Medicaid program. So the QuickBase system that we do have in place that has been modified extremely by Jeremiah Fale. It's a very user-friendly system, but it does not, whatever layers that are added onto the QuickBase, these are layers that actually help us move forward and progress faster. So every day there's always if we see that this can be done a certain way so that the process is much faster, then we will advise Maya. And when those layers are added onto the system, it pretty much streamlines everything faster, but it does not delay any benefits for our beneficiaries that are registering and enrolling of type.
So in regards to your question about E&E for the beneficiary, so anything related to Medicaid beneficiaries, that's the E&E system for the eligibility and enrollment. MMIS is specifically for our agency and our service providers only, because on a compliance side, when we have the E&E system, it is a lot easier for us to check verification. So we have, with how CMS does it, is that we will be able to access certain federal databases securely, because right now we're unable to do that because we don't have certain certifications and standards that CMS requires. So it'll be a lot easier for us to do the eligibility and enrollment when we have those systems in place and stay in compliance with federal law.
There's a question from Department of Health team.
Thank you, Maya. I'm here with Department of Health, but I'm also a reservist in the Army. So I'm going to ask a question on behalf of our military benefits. So for myself, I'm a reservist, so we don't get the benefit the active duty side has. We pay a certain premium amount every month. So when we go to the hospital, we do use our TRICARE Select insurance, and it only covers 60% of the medical bill. 40% is out of pocket. Will that hinder me from being eligible as a Medicaid beneficiary?
Thank you. I'll direct you to Matilda to clarify the...
Thank you for the question. It does, so in regards to eligibility for you having TRICARE and Medicaid, so how Medicaid works is that if you are eligible, you can still be considered what's called a dual eligible beneficiary. So you can have private insurance, you can have Medicaid too, because we would always be the payer of last resort. So what would happen is LBJ has to utilize your primary insurance first, and whatever's remaining, which is the 40%, automatically comes to us and we pay for the service. So long as you're eligible for our program, we can do that.
Basis facility the floor before we move on to the questions that have been asked via the QR code.
I just wanted to follow up on with Matilda's response to the question. We are able to cover the 40%, and that is for local services. And if you do go off island, you would need a referral from LBJ for us to be able to cover that 40%.
Thank you, Deputy. Is there any other questions on the floor before we proceed forward with the Q&A that's on the screen? Perfect. I guess we can start with the first question. What challenges can Medicaid help overcome to enhance technology for our people? I do believe that majority of our people are not really tech savvy. With the new generation right now, everything is a barcode scan through the phone, or we're using a QR code. As we are trying to expend and procure all these systems, we are also looking into trying and provide eligibility and enrollment space within our office to help our old folks come into our office and have our employees assist with the process of applying for Medicaid benefits, as well as trying to modulate them that there's new technology that maybe they can bring in their children just to shadow the process, that when they apply for another application, maybe a vision from home, they've already know the process as they go along. Tina?
So to add on to Maya, I think the number one thing that would help improve our services is just accessibility. People are able to register at their homes at their own convenience to apply for our Medicaid services. The second thing it will help is portability. Now that we have this E&E system, we're able to issue you cards to say you have Medicaid coverage. So then it's a lot easier for you to receive your benefits and coverage if we have some sort of system in place, like other typical Medicaid programs. So it's accessibility and portability is what we're looking at.
Thank you. The second question is, what infrastructure automation tools are you considering? Examples, and that is, it can be a QR code, it can be a link to the applications, and you can apply from anywhere instead of walking to our office, manually applying for all these services. These are some of the automation tools that we're talking about. You can have the QR code on your phone, and as Celia was explaining, that you're going to receive an ID to tell that you're a beneficiary of Medicaid once you apply for all these services. So those are the automation tools that we're looking at. Once we procure these systems, I'm sure everyone is going to have a flow of application, as well as receiving the status of your application as we go along. Is QuickBase a solution for beneficiaries to confirm eligibility of provider services electronically rather than going in person to the Medicaid office? As of now, that is not the answer. It's a no. QuickBase is not the solution for beneficiaries, and that's why we're working so hard to have this E&E approved by the final step of approvals. And once we procure that, we will go ahead and proceed forward. The second one is, are you willing to provide Medicaid provider access to your infrastructure automation tool? Yes, that is the intent of the office once we procure all the two systems in place. As of now, QuickBase, you will have access as a provider to see all the beneficiaries that we share. But other than that, other automation are not able to practice or implement, only because it's a off-the-cuff solution where it has limited modifications to it. Can you share how statistical models and trends are being used for data-driven decision-making for health purposes? I can definitely show you that, but as I said, the statistical models and trends from the data that we've been collecting that has been shared with LBGN, DOH, and all other service providers under the Medicaid DME vision, these numbers we use to justify, to provide to CMS if there's any questions regarding from the services, and then we determine the trend per quarter, per year, how it goes up, and then it falls back down. The prime example is the demonstration period that we conducted last year, and I'm sure a lot of you have questioned why our services got suspended from March to September, the ending of last fiscal year. And that is the primary example that I can give you, because the trend really dropped down to zero because we never served any patients within the period of time. If MMIS is approved in the near future, will Medicaid be able to manage the aftermath? I'll give it to Tile to share on that.
So I just want to provide some background of why we have to implement MMIS. So the Medicaid Management Information System was actually made a requirement by Congress that we had to implement in our agency in order for us to get our increased CAP funding and increased FMAP rates. And they gave us a deadline of fiscal year 2027 to have this fully operationalized. So if we do not have this system in place, we could be at risk of losing some federal funding and FMAP decreases. So in terms of the aftermath, I think losing the federal funding is more critical to us, and we're trying to make sure that stays with us. We will be reaching out to our service providers once we have to start implementing MMIS to teach them how to utilize the system, especially with whoever is going to be our contracted IT system. So I hope that answered your question. When you're talking about AI in the first question, there are, for the MMIS and E&E, there are certain state Medicaid agencies that are using AI models to help sift through the data and find, like, especially when it comes to program integrity, to see where are the trends in fraud schemes in their systems. We could look into it, but you also have to look at the ethical side of it, utilizing you're teaching these AI model tools with PHI. So we have to be considerate when we use any sort of artificial intelligence.
Thank you. The other question, how will improvements in the infrastructure reduce downtime and enhance processing? In the Medicaid agency, I don't believe there's any downtime. And I do believe in other agencies and other departments, I don't think you have any downtime for throughout the day unless you have a current schedule pertaining to your staff per day. But for the improvements of infrastructure automation, if we do have these two systems, it'll really help us eliminate any errors only because of the pen and paper process. And also, like what Tile was sharing, we will do internal training as well as for our providers to make sure that they know every bits and pieces of the system as we go along to eliminate any confusion. Is there any backup and recovery solutions are in place for system failures? Right now, we do, for QuickBase, there is a back end on QuickBase that stores the data that we've been collecting. But this is more importantly, if we do procure the two systems, we will look at the back end of the system to ensure that there is a solution to upload all these information once we procure the system. And that is part of the process that we're heading into for E&E as we try and procure a contractor for the IT system. These are some of the factors that our agency will have to look into, that you have to have these factors in order for us to determine you as a vendor for the system. Is there any other questions on the floor? All right, I believe that concludes our IT presentation. I have a quick exercise for all of us before we give the floor over to our finance team. I encourage you to participate. We do have our giveaways. Let's recall your memory data. Real quick, two truths and a lie. Two truths and a lie. Eligibility and benefit rows. First aid. What do? Review all referrals. Provide pocket money. Coordinate logistics. Which are the two truths and which is a lie?
Here.
Dr. Anaise? Correct. May I have a giveaway for Dr. Anaise? From Ulmole staff, if you can see whose hand comes up first.
Yes.
Service providers, Eyesight Hawaii, Talofa Airways, Department of Health, which is a lie.
Luisa's hand was up.
Talofa Airways, may I have a giveaway for?
Not yet.
Next one, reasons for denial. Medicaid diagnosis not covered under Medicaid state plan. Unavailability of medical providers. Registration unsuccessful. Which are the two truths?
Oh, registration unsuccessful.
Sorry, which are the two truths?
Which are the two truths?
Unavailable medical records? All the two truths.
The two
Medicaid
truths.
diagnosis and unavailability.
You have a giveaway for
That is correct.
doctor? Medicaid state plan. Execute order of single state agency. General provisions. Government provisions. This is a little tricky. Which one is a lie?
Christina?
Oh, general
The
provisions?
first one's a lie. Execute order.
The first one is a lie. Nope.
General provisions?
Nope.
Luisa? Lori? Government provision?
Government provisions. Can I have 3 for all the participants? Thank you.
3 for our participants. Day 3 giveaway.
Okay, program integrity activities. Oversee and manage Medicaid provider enrollment. Reimburse Medicaid claims. Support outreach and education to Medicaid stakeholders. Which is a true? Which is a lie? Sorry. The green one.
Can
May
I
I have
get a
a
prize
giveaway
for the
here,
green
please?
one?
All right, that concludes our presentation this morning. Thank you, everyone. Now let's take time over to our finance division.
Baftai, Jeremiah, Mina, if you can just get 3 minutes, Famulmole, you can go ahead and prepare. But Maloa, Baftai, Jeremiah, I hope everybody and everyone here had an understanding of what health information technology is. Right now, I'd like to turn the mic over to Director Kwaya for a mental break exercise. Thank you.
How are y'all doing today? Great? Okay. We're just going to refocus and reset. So I want you to all sit comfortably, empty out your hands right now, and let your feet touch the ground. Close your eyes if you're comfortable, or soften your gaze. We're going to do some breathing techniques right now. So take a deep breath in through your nose. 1, 2, 3. Hold. 1, 2, 3. Exhale. 1, 2, 3. Let's do that again. Inhale. 1, 2, 3. Hold. 1, 2, 3. Hold. Exhale through your mouth. 1, 2, 3. Let's try it again. Inhale through your nose. 1, 2, 3. Hold. 1, 2, 3. Exhale through your mouth. 1, 2, 3. One more time. Inhale, deep breath. 1, 2, 3. Hold. 1, 2, 3. Exhale through your mouth. 1, 2, 3. Now bring your attention to where your body touches the chair. Notice your feet on the floor and let your shoulders drop and relax your jaw. It takes a little focus. Notice where your body touches the chair. Notice your feet on the floor. Let your shoulders drop and relax your jaw. Now for the center, bring to mind one intention you have for the rest of today. Maybe it's to listen more, to stay curious, to be kind to yourself. And I want you to hold that intention in your heart and take one more deep breath. And when you're ready, gently open your eyes, wiggle your fingers and your toes, and welcome back.
Lava Director. Our next presenter is our staff accountant, the acting division head for our finance division. And I ask that you please pay close attention to her presentation because this is a very critical and important aspect of Medicaid. It's the payments, the percentages we use, and why we use them. So I would like to bring up Mrs. Wilhelmina Sailua Tongafau.
Talofalava, everyone. I hope you are relaxed after that wonderful exercise by Madam Director. And welcome to the finance portion of our 2025 Medicaid Medical Summit. My name is Wilhelmina Sailua Tongafau, and I am the staff accountant for Medicaid. My colleague to the left, back of the room, Mrs. Nemo Mangel Salavea, is our wonderful accounting technician. And we are the worker bees of the finance division. Our division head, Mrs. Epifania Yosefo Solofa, cannot be with us here today, so I will be presenting in her stead. Our finance division consists of 3 team members. While finance may be a heavy lift, don't be fooled by our small number. We are the fulfillment of the Samoan proverb, Elaititi ai maini. Epi, Nemo, and myself, between the 3 of us, manage 7 different Medicaid accounts, compile and certify quarterly federal reports, as well as local reports. We process reimbursements for administrative vendors and medical providers, organize and keep records for all claims processed, and heavily monitor our most important account, which is our local Medicaid subsidy, better known as local match. Local match is our favorite word here at Medicaid because that's what we cry about all the time. So before we start on the finance portion, I'd like to take a quick survey of our audience today. Do we have any current or potential providers in attendance today? Please raise your hand.
I see MedQuest,
Okay,
Lisa.
a few.
Hope House.
Any community stakeholders or beneficiaries?
Everyone.
A few more. How about our AHG counterparts? I see budgets in office. Oh, DOH, yes. I'm happy to see a good mix in the audience today as this information pertains to everyone. So without further ado, let's dive into the exciting world of Medicaid finance. First things first, governing Medicaid spending. All Medicaid agencies are governed by a code of federal regulations, also known as CFR. It's the legal framework that ensures government agencies comply with established statutes and provides transparency to the public. Medicaid is covered under 42 CFR 4. For a copy of this CFR, Google is your best friend. Each Medicaid agency is further governed by a document specific to their state, known as the Medicaid State Plan, which was discussed extensively the past few days. This is our Medicaid Bible and has all the information pertaining to our program. A QR code is conveniently provided with a direct link to our latest state plan should you wish to obtain a copy. Attachments 4.19A and B pertain to Medicaid finance. The first part to understanding our claims process is understanding the presumptive eligibility concept. As mentioned yesterday by our Deputy Director, American Samoa Medicaid operates under a presumptive eligibility concept. Moving forward, we will call this the PE. This means that all bona fide residents of American Samoa are presumed eligible for local LBJ and DOH services. All services outside of these public facilities are subject to federal and state plan requirements. This means only those individuals who meet the beneficiary criteria stated in the state plan are eligible for services outside of LBJ and DOH. However, due to the establishment of the Ainga Care in December of 2024, a portion of our $6 million local match budget has been earmarked for individuals who hold a CA or AA immigration status. Now, what exactly does this mean for this population and Medicaid? When Ainga Care was launched last year, Medicaid earmarked $500,000 for local DME services for CA and AA immigration card holders. As much as we'd love to expand these services to more populations or immigration categories, we just don't have the funding to do so. And once again, our local match is our crutch. The costs for Ainga Care program are claimed at 100% local, as we are not able to draw federal dollars for this population. And this leaves us with $5.5 million to draw our federal funds. So every year, American Samoa, our Program Integrity Division, compiles a PE report utilizing data collected from different departments and offices such as the Immigration Office, DOC, and the Census Office. This data is then input into a pre-approved CMS formula to determine the claiming percentages of the upcoming fiscal year. In September of FY24, Mr. Jeremiah Fale, our acting IT division head, compiled this report from which our FY25 claiming percentages were derived. I don't believe we have a QR code for that. So if you would like a copy of our FY25 PE report, I'd be happy to email it over to you if you see me after lunch. Our PE claiming calculate percentages for FY25 are as follows. We have the MAP, Medicaid Assistant Program percentage, at 40.36%. The Children's Health Insurance Program, also known as CHIP, at 9.26%. The emergency claiming percentage at 32.04%. And the Medicare PE percentage at 90.14%. Feel free to jot these percentages down as we will have an exercise later on down the line. So American Samoa is the only state agency that operates under the PE model, while all others use individual enrollment. Because of the PE model, when we process for reimbursement, we calculate the MAP, CHIP, and emergency claiming percentages together for all eligible claims. In addition to the PE, there's also the Federal Medical Assistant Percentage, also known as the FMAP. This determines the federal government's share of Medicaid spending in each state, ranging from a statutory minimum of 50% to a statutory maximum of 83%. The way the FMAP is calculated is based on a formula that considers each state's average per capita income relative to the national average. So states with lower per capita incomes typically have higher FMAPs. For American Samoa, our current and permanent FMAP is 83%, which is the maximum allowable. During economic downturns or for specific circumstances such as disaster relief, the FMAP can be adjusted. A prime example of this would be our COVID years. American Samoa received an adjusted FMAP of plus 6.2%, which took our FMAP from 83% to 89.2%. This allowed us to draw more federal dollars per claim. After the public health emergency period, our FMAP reverted back to 83%. For the Children's Health Insurance Program, the CHIP, there is an enhanced FMAP of 85%. Now this is where it gets a little confusing, but for those of you who love math, it gets fun. Okay. So we have the PE claiming percentages for MAP, CHIP, Emergency, and Medicare. On top of that, we have the FMAP percentages for CHIP. We have the FMAP percentage for MAP and Emergency and all other services. And when we combine these percentages, we get what is known as the true FMAP. Only American Samoa has a true FMAP because we are the only ones who operate under presumptive eligibility. I'm not sure if anyone wants to hear the formula. It might confuse you, but here it goes. This is calculated, the true FMAP is calculated by the following formula. We take the sum of MAP and Emergency PE multiplied by the FMAP, add it to the CHIP PE multiplied by the CHIP FMAP, and then that will give us the true Medicaid FMAP. Now, if we're using the percentages that I showed you in the previous slide, we take 40.36% plus 32.04% times 83%, add that to 9.26% times 85% equals 67.96%, which is our true FMAP. Fun, yeah? So our true FMAP is 67.96%. This means for every $100, $67.96 is drawn from the federal, and $32.04 comes from our local match, as opposed to other states which can draw $83 per $100, which is a pretty big gap. So the impact on our state match or our local match is pretty high. For reference, I'm sorry, I think my slides are all over the place. Okay, are we here? Okay. Just for your reference, there's a different claiming formula for different services. Regular Medicaid payments are calculated differently from Medicare co-payments. DME reimbursements have their own formula to calculate the federal portion versus the local match. LBJ has their own claiming. So each service has a different formula for calculation. And so to avoid the confusion, we just have a different calculator on a spreadsheet for each service when we process for claims. So how do providers get paid by Medicaid? One of the most important parts of signing up as a provider is to have a payment methodology. I believe this could pertain more to EMS as they are currently seeking a payment method to becoming a provider. Without a payment method, we cannot sign you up as a provider because we need a way to reimburse your services. The second part is the service must be stated in the state plan. If it's not a service in the state plan, we cannot reimburse you for that, for any of your claims. Once it's in the state plan, you enroll with Ms. Matilda Cruz as a Medicaid state provider, and once you complete these steps, you can finally submit your claims to us for reimbursement. The third part is also an important part, is eligibility of the patient or the payment. The patient must meet the eligible beneficiary criteria mentioned in the state plan, and except in cases of emergencies where everyone is eligible. So the following is a list of our providers, their payment methods, the local matching fund, and then the required documents for submission of their claims. So LBJ Hospital is our biggest and our first provider. They operate under the Certified Public Expenditures, or CPE. That is federal reimbursement only, and they do not require a local match. I believe Matilda touched on that yesterday, so I won't repeat myself. What happens is they submit a CPE certification to us monthly, and we reimburse them based on the CMS approved amount. Our FQHC is DOH. I'm sorry, I should have mentioned that. DOH is formerly known as the Federally Qualified Healthcare Facility, and they are paid by encounter. Currently, we reimburse DOH $150 per encounter, and DOH has their own local matching fund, which we are very grateful for. So it doesn't, there's no impact to the Medicaid local matching funds. And they submit to us the same way LBJ does, monthly, with a total of their encounters, and then they apply the percentages we discussed to determine how much is to be reimbursed to them. Our DME providers, MedQuest Medical Supplies and Genco, use the Hawaii Medicare fee schedule, and they submit invoices to us. Hope Dialysis, who was a provider under the PHE and is now a potential provider, their payment method is Medicare copay. So the patients with Medicare, Medicare pays for their 80% and they submit to us the 20%. Those without Medicare, Medicaid covers the entirety of the dialysis treatment. And their local match comes out of our Medicaid subsidy, which was approved by the FONO. Hope House has daily fixed per diem rates. They are also another provider with their own local match, which we are also very thankful for because there is no impact on our local match. And they submit to us either monthly or quarterly for reimbursement. My Vision Eye Care is another DME provider, and their payment method is approved CMS fee schedule rates. Their local match also comes out of the Medicaid subsidy. And what they do, they use our QuickBase system that Jeremiah talked about, and they upload the invoices to the system, and it pings us, and it'll to notify us that there's an invoice that needs reimbursement. Medisys also uses our QuickBase system to upload their claims, and they also use customary charges. My Vision and Medisys local match also comes out of the Medicaid subsidy. Okay, let's see. Now, let's take a dive into these claiming percentages. Our claiming process. So when Medicaid receives a claim, it goes through an internal review process. NEMO is usually the one that processes the claims. What she does is she reviews the claim for eligibility, if it's an eligible service, and if the patient is an eligible beneficiary, before she applies the percentages to the calculation. The goal is always to ensure compliance with eligibility requirements and proper documentation to facilitate timely payments. Once NEMO is done with her review, the eligibility check, it goes through an internal approval process. NEMO submits to me, I check if the percentages are correct, and then I'll sign for approval of payment. Then it goes to our division head, who further checks, and she is another set of eyes that checks if all is in order. Once she determines that the claim is properly, the cost is properly claimed, it'll go to our director or our deputy director for their approval signature. And once they approve, then the routing process starts through the intergovernmental agencies. Our first stop is the budget office. This is where our budget analyst, Lina or Joe, encumber our claims. When we process the claims, we determine exactly how much is to be encumbered and drawn from each account. So when it gets to this point, all they do is make sure the funds are available, and then they encumber. There's no calculation that happens at this point. They just encumber exactly the numbers that are on the voucher. So the budget analyst reviews if the funds are available, and they encumber. And then it goes to the budget director for final approval. This is an internal, I believe this is an internal policy with budget where if the voucher total exceeds 5,000, the approval must be granted via the director or the deputy director. But if it's under 5,000, we just need the analyst's signature for approval. And then that completes the budget office part of the claims process. After budget, it moves over to AP. So accounts payable, we drop it off to AP and stamp for their received approval, and then we make our copies for our records. We realize that this is an important part for us because a lot of times when we follow up with our vouchers, it kind of gets lost in the process and it's hard for us to track. But if we keep the records of the fully executed voucher after AP stamps, then it allows us to go back to AP and give them the queue numbers or whatever information they need to move on with the payment. After we drop off to AP, that completes our portion of the routing, and it's just a matter of following up and following up and following up until we get a check. Yeah. Now to our favorite word of Medicaid, local match. Whether you're a provider, a beneficiary, or a government stakeholder, the Medicaid finances affect us all. And at the end of the day, our formula is simple: no local match, no services. And to be more specific, at this point we're realizing no cash flow, no local match, no services. So having an adequate local match to support the federal match grants each year allows us to ensure uninterrupted access to care for all our beneficiaries. Once the local match is depleted, or once it reaches a certain threshold, Medicaid will be forced to suspend all services to protect our credit with providers, so that in the event our local match is replenished, we can just resume instead of ruining our credit with the providers and having them cut us off altogether. FY24 was the first year Medicaid had to suspend services due to the depletion of our local match. It was a sad year for Medicaid, but that's the reality of our program. Federal dollars are only as good as our local match. And until Medicaid receives enough local match to draw down the full federal funds, we continue to return to CMS millions upon millions of dollars. And it's not for lack of necessity. I can't help but imagine how we could transform our local health care if we had the ability to draw down the full $90 million in federal funds. The possibilities are endless, and I look forward to a day when we can do just that. So until that day, our cry will always be more local match, please. I leave you with my heartfelt gratitude for your time in exploring this wonderful world of Medicaid finance. I hope to leave you today with a better understanding of our financial framework and a newfound appreciation for the heavy lifting we do on a daily basis. I pray you will all take this knowledge and share it with those who weren't able to attend today, or direct them to our office for any and all questions. Before I end, I just have 2 exercises prepared for you guys, so we will be doing a little bit of math work today. So you can spend a day in our shoes. Welcome to the world of Medicaid Math 101. Our first exercise will be a Medicist claim. I've provided the formula for you up here. I hope you took notes of the percentages because you will need that to input into this formula. There are also prizes for these, for those who get the correct answer. If not, you will be penalized by the federal government. Okay. Yeah. Who needs a copy of the percentages? Was everyone able to make a copy of the percentages? Okay, let's go back to the percentages so you can take a screenshot or a photo and okay, they're still writing. Okay. So we have a Medicist claim. We received a Medicist claim, Medicaid finance workers. Are you guys ready? We received a Medicist claim of $300. Now you take that total claim, multiply by the MAP PE, multiplied by the emergency PE, multiplied by the MAP and emergency FMAP. So we take 300 times 40.36% times 32, Actually, that times in the middle of MAP and emergencies should be a plus. Gotcha. I'm just kidding. So MAP PE plus emergency PE. Multiply all that by the 83% FMAP. Who was able to come up with our federal portion? And be careful, the federal government is watching. I'll give you a minute.
Any mathematicians in the building who want to give it a go? Even if your answer is wrong, you'll still get a prize.
I'm glad you're finding it difficult because this is what we do every day. Oh, right here, Ozzy, we have a... DOH, you also do this calculation. What's taking so long? Jennifer Sewell, what's your answer?
I didn't get it.
You got it, Lonnie.
Is it $32.19?
What was that?
$32.19?
For the federal, MAP federal portion,
Yes.
if I have a $300 Medicist claim, remember the MAP PE plus emergency PE. Sorry, that's not correct.
$38.79.
No, I'm sorry. No. Yeah.
Dr. Falitua?
Is it 336 and 70 cents?
I'm sorry, I didn't hear that.
336 and 70 cents?
No, I'm sorry, the federal portion cannot be more than the claim. This will put us in deep violation with the federal government.
So is this like emergency times FMAP? Is that?
Yes, so
or
the
emergency
correct
plus-
formula is the total claim. You add these two percentages first. This should be a plus. Add
should be
these
a
two
plus,
percentages. Total claim times the sum of these two percentages times the FMAP. Falling on one exercise.
We are trying to find the federal claim portion.
We're just calculating the first part.
181.17.
You're the closest, yes, yes. So it's roughly 180.28. So we have a close winner. Yeah. So now we're going to calculate the CHIP portion. That's the first portion of our calculation. The CHIP portion, we take the total claim, multiply the CHIP PE, multiply the CHIP FMAP. Who wants to take a go at that? So we have 300 times the CHIP claim, the CHIP PE, which is 9.26%, multiplied by the CHIP FMAP, which is 85%. I'm sorry? 236.13. What did you say?
236 and 30.
Lisa?
Yes, that's correct, Lisa. I would hope DOH would have the correct percentages. So to calculate the local portion, we take the total claim, we subtract the MAP claim, subtract the CHIP federal claim, and what we're left with is our local match. Who can give me the local match? This is the easiest part of the calculation.
Hey, we have an answer here.
Ma'am, what was the MAP claim then? What was the number that you got earlier?
180.28 is MAP.
180.28.
28.
Okay.
23.61 is CHIP. And the local is whatever you get after you subtract that from 300. Yeah.
Mina? $96.11?
Yes, that is correct. Thank you. Can we get a prize for this winner? Next one. Okay. Are you ready for your next exercise? Just kidding. Okay. I'm glad you're all enjoying it as much as I am. This one's an easy one. We have a Medicare co-pay claim of $700. So the formula for that is we take the total claim, multiply the Medicare PE, multiplied by the MAP FMAP, which is 83%. So let me know if you need the Medicare PE percentage.
Medicare is 90.14.
523.71.
Yes, that's correct. Thank you, DOH. You will be getting your reimbursement this month. Okay, who can give me the local portion? besides DOH. That is correct. 176.29. Someone get DOH another prize. Okay. All right, so some key takeaways from today's presentation. Medicaid payments in American Samoa are governed by both federal regulations and specific provisions within our state plan. Providers are reimbursed according to specific guidelines outlined in the state plan, and changes require formal amendments. The FMAP and PE models play critical roles in determining funding and eligibility for services. And the final takeaway, the payment process from receipt of claim to remittance of payment involves collaboration between multi-governmental agencies. Complete processing time may vary, but to be conservative, it may take up to 2 to 3 weeks to receive a reimbursement. It just depends on the cash flow and local match. Now, before I open up for Q&As, I'd like to address some of the questions from yesterday's online discussion before I open it up to the floor. Maybe it might answer some of your questions you may have. The first question was, for potential service provider applicants, how do we go about in seeking a local match for our local government, from our local government? Unless you have a revenue source, your first step would be to set up a meeting with the governor's office, key personnel, to seek local matching funding for whatever service you're provided. Granted, it's an approved service in the Medicaid state plan. As we are currently under the governor's office special programs. A good example of this would be Hope House. They sought local match funding with the previous administration and were able to secure their own local funding, which is good for us here at Medicaid. Only 2 providers have their own local match, is DOH and Hope House. All other provider local portions come out of our Medicaid subsidy. The second question was, can you explain how the FONO appropriated local match is budgeted for specific providers and services within your state office? So whatever we receive from the FONO, whatever's approved and appropriated from the FONO, this year is $6 million minus the Ainga Care 500,000, which puts us at 5.5 million. That all goes into one account known as our Medicaid subsidy account, and it's utilized on a first come, first served basis. This means we draw as we receive claims. All local match requirements for medical only across all providers, with the exception of DOH and Hope House, draw from this local funding. So there's no specific budget per provider. We just draw until we reach a certain financial threshold with our local match, and then we suspend services. The third question was, how does DOH and LBJ have their own local match, and how much is required for both entities? I believe this was addressed yesterday by Ms. Matilda, so to avoid repetition, I'll just go over that one. I'll skip over that one. How do you assess the balance between the cost and increasing need for cancer care? Unfortunately, cancer is not a covered service under our state plan. And during the demonstration period, it was confirmed that cancer treatment was too high and unpredictable of a cost to cover with our limited local match. If we ever make the move to cover cancer, the most fiscally responsible path would be to start with our dual eligible Medicaid, Medicare beneficiaries. This way, Medicare can cover the 80% and will apply the Medicare claiming formula to the 20%, which further gets cost shared and divided between federal and local. And that, I believe that's it for yesterday's online questions. And at this point, I would like to open up the floor for any questions you may have for me.
There's a question?
Thank you, Wilhelmina, for the great presentation. My name is Luisa Baumi. I work with Department of Health. So my question is in regards to the local match. Do you believe that the delay in payments at the Treasury level would be a cause for lack of local match? Because if we don't pay our bills because of the red tape workflow that we have currently, would you think that impacts our local match? Thank you.
Thank you, Luisa. So the local match is there and available. It's budgeted and appropriated for medical services. The availability of local match doesn't delay payments. It just determines whether we keep or suspend services. The delay happens with the cash flow issues that ASG receives. As you all know, whatever cash comes in, whatever revenue is collected by ASG, it gets divided amongst all other agencies. And so it's just a matter of prioritizing Medicaid medical payments in order to receive timely payments.
Another question, because I deal with medical supplies of the DOH. So since MedQuest is a DME provider, are we able at the clinic level ask for supplies that can be eligible for our patients at the clinic?
I'm sorry, you're asking if you're able to ask for supplies through our provider?
Or, from like wheelchairs, wound care supplies, especially after a patient is released from either LBJ or DOH, they need medical supplies to take with them home. I feel like sometimes when we have our patients go to the hospital or, after they are released from their care, they have these supplies that sometimes come out of pocket.
I can answer your question. So, in regards to the DME reimbursement program, there are only 2 facilities we actually allow to when Austin said we require prescriptions. It is the DOH clinics and LBJ. So when we talk about prescriptions as the requirement to receive durable medical equipment, we have to see a prescription from LBJ or DOH.
Question here with Dr. Anais.
So for those of us who have new doctors or physicians at DOH who doesn't know how to provide this reimbursement, I remember going last year and I was thinking, I have sleeping apnea. I think I need a machine. Can you write me a prescription? And she's like, oh, I don't know how to do that. Is it some sort of refresher training for our physicians? Like, are you willing to come over and talk with our new ones?
So what you're trying to say is the doctor was not sure if she was qualified to write the prescription? That's actually DOH's job to educate your doctors on. But what we can do is educate the process of how we do the eligibility for the reimbursement. So it has to be when you give us the prescription, there also needs to be medical notes stating the medical necessity for that durable medical equipment. But in regards to writing the medical notes, if the doctor is unable to do that, I would ask the Health Regulatory Board to help them with their credentialing.
Yeah, I have a question, please. Dr. Usu, you were referring to which equipment? Oh, the CPAP machines, yes. Yes, that is the role or the task or responsibility of the physician to instruct. And we also have respiratory therapists at the hospital who can also help out with those patients who are on CPAP. I want to comment our team here on my far right from DOH for winning all those prizes. I'm hoping that Medicaid would give us additional reimbursement for all your efforts as being great calculators and mathematicians. Thank you. My question, because at this point we understand that what we get from Medicaid depends on the encounter forms. And So I'm thinking if we do not have enough patients coming in at one point or one day, so that all depends on what we receive. Is there any other way or some sort of fixed way that public health DOH can receive a bit more fund than depending on the encounter forms?
So DOH, before your reimbursement, encounter rate was at, I think, a double-digit reimbursement per encounter. Right? What was it? Yes. Currently, it has been increased in the past years to $150 per encounter. And that's the only payment method DOH has currently. So that's the only method we are able to reimburse you by.
I'd like to add on to Mina's response. Like over the years, and which is one of the main reasons why we increased the encounter rate from 50 to 150, because we saw that there was an increase in for our people to come and use CHCs instead of going to LBJ. Another thing would be, it's not just Tafuna CHC, it's all the CHCs from Aunu'u, Amoli, the two Manua Islands, Tafuna, Leone, Whanga'alu Tūtile, and Whanga'alu. So all of that calculates all their encounters. That's how we determine the 150 encounter rate that we have now. In terms of a fixed or another way, when we do see the trend that it decreases, we can talk about other ways to be able to give Medicaid funding to DOH. But as of now, you know, we've seen the increase, and I think we are okay with that right now.
Another thing that DOH also needs to take an account of is we need to see the data. If your expenditures are increasing and it's also impacting your medical services, it's good for us to know, because then we can revisit the state plan and see if we can increase your encounter rate. Because technically right now, we're utilizing an encounter rate for that usually all CHCs across the country. And right now, I think the rate right now is like $185 or $3. So there is a possibility, but without the data, we cannot increase it, because CMS, their first question they're gonna ask is, where's the data? Because the first thing they're wanting to check is, well, how much is that going to impact us in terms of federal dollars? And also, I think recently I did site visits at all the local Tutuila clinics. Eventually we're going to do Manua and Aunu'u. And essentially with these site visits, it also helps us reassure and reaffirm all the services that we are actually, all the services we are immersing, we're verifying if these services are being done. Another thing it also helps us to know too is maybe when I go to these site visits, I see, oh, you're doing more services than I thought. How come you're not letting us know about these services? So that's another thing that we learned, especially with like when we finally fixed the well baby, adding them as an encounter. So DOH is able to receive more, draw down more federal.
Lastly, CPE is also another payment method you can explore, but that's a conversation. It's a really big lift and a conversation we can have on the side. You would need to be a Medicare provider if you want to go the CPE route and do the Medicare cost reporting. But we can explore that more extensively off to the side.
We have a question here.
Malo lava soifua. We're from Department of Education and the Special Education Division. And so we're just asking how the Medicaid program can assist us with our students with disabilities in regards to their wheelchairs and special equipment.
Tila can elaborate, but the short answer is we have a durable medical equipment vendor, MedQuest Medical Supply and Genco Medical Supply. What they would need to do is obtain a prescription from the doctor and then submit to us for eligibility, and we submit to them for processing and giving out the medical equipment needed. So if it's children, children are automatically covered, and it's easier than covering adults under the CHIP program. And so it's a lot less of a process to provide the medical equipment to the children. If Tila would like to elaborate.
To follow up on your question, on the compliance side, when we're trying to reimburse these wheelchairs, any sort of special equipment, when we're looking at the billing side of medical, it has to be individually itemized. And that sometimes takes time because a lot of people don't understand how to utilize what's called HCPC codes. And within those HCPC codes, they have, it's not just that, it also tells how much we can expend and reimburse for those services. So it's something that I know we have to work with our supplier to try to fix that gap, because that is an issue too, and we acknowledge that.
I also think we need to discuss with the Department of Education director, because I know there's a lot of grant funding that currently funds SPED account, and I'm not sure what exactly it's covering, but we do have funding. I mean, we're the insurance component to reimbursing medical needs and medical equipment that can't be provided within the departments. So there's statute written and policy written for DOE, but I don't think the conversations had taken place to see how Medicaid can support the children of DOE in their health care. We had a parent here yesterday talking about their child being on the spectrum with autism and just a lot of special needs and disabilities that DOE is currently funding or supposed to be funding through their grant blocks. But the conversation between how Medicaid should be supporting that hasn't taken place yet, and we're open to that. That's why we're here for the summit, to start collaborating with the different departments to see if it is written in our plan, if we have the funding for it, how it impacts our local match. But as we've stated time and time again, Medicaid is the last resort of payment for a lot of the funds and services that are provided here on island. But we are open to it, and be more than glad to talk to Dr. Mary about it.
Yes, sorry, just to add on, but the services that we can offer you right now, especially for the special needs students who require not the extensive, fully electric chairs, but for students who do need the standard wheelchairs, those are available right now, and you can have them come into our office to register with us, because those are the wheelchairs that are available locally with MedQuest located at the Pango Plaza.
Are very severe, so they need a special designed wheelchair. It's not just a standard wheelchair. Most of them have different accessories. They have their own measurements because of they're so severe that they need accessories, specialty to meet them.
Customized.
Yes,
Customized wheelchair. We were able to talk about that yesterday, and Matilda explained just now that we are able to do it, but we just gotta have it itemized, and that's something we can work with MedQuest. In fact, we do have one that we are currently working on with MedQuest, and it's going to take time, but we can get it done. Thank you.
Thank you. I spent the last 3 days here at the summit, and I don't think I'd be doing our department justice if I didn't ask some questions here. I understand the difficulties or the complexity of the position that the EMS or emergency medical services in. However, there is no building system present at this time. One of my questions was, is it possible for LBJ to do the billing for us and we still provide the service while we are with ASG?
Currently, Medicaid reimburses LBJ for ambulance service, emergency services, up to the tune of roughly about $250,000 a month, if I'm reading this PE report correctly. So we do reimburse LBJ for ambulance services, and if you want to speak with LBJ about receiving those funds, I think that's a conversation you guys need to have, and a collaboration you
Well,
need to
thank you for that confirmation, number one. The other question that I had is, so if we're talking about compliancy here, unless LBJ has their own ambulance service, if you've been reimbursing LBJ for ambulance services over the last 2 years, because we have not been part of LBJ for the last 2 years, so what ambulance service is that money going to?
I believe that's a conversation you would need to have with
Okay,
LBJ.
thank
But when
you
they
very
submit
much.
their certification to us, their public expenditures, it does include ambulance services.
Okay.
Yes.
Thank you very much for
You're
that
welcome.
clarification. I appreciate that.
Any other questions?
I want to elaborate just on Chief Faita's question too, because search and rescue is a new a department that was formed and actually moved from LBJ, and their statute created to establish search and rescue. And so I think this is definitely a conversation that should be happening at the governor, with the governor, and also with the key stakeholders at LBJ and search and rescue to understand where that funding is going. That isn't anything from Medicaid to determine or assess, because our service provider is LBJ, and we do not have an existing service provider agreement with search and rescue at this time. And so those are conversations that should be taking place with your director as well as LBJ CEO.
Okay. Anyone else before we move along with our program? Do you have anything else, Mina? Okay, go ahead.
At the moment, but do you want me to address some of the questions?
Sure.
Yes. All right. So the first online question is, are there efforts to advocate to have a FMAP of 100% similar to AI and AN populations? We currently reimburse at the maximum statutory FMAP of 83%. I believe during Obama's time, when we had the ACA funding available, it was a temporary increase of 100% FMAP. But currently, we are operating under the maximum 83% FMAP.
Hello. Sorry, I want to clarify. Are you asking about the Native American FMAP? The Native American and the Alaskan Natives? So in order to get that sort of FMAP, we actually need a tribal designation. and we're not considered a tribal designation, similar to like Hawaii. So if we want to advocate for this sort of FMAP, it's an act of Congress. So we would have to work with Amata's office to do this sort of heavy lifting.
Second question, what Medicaid-related data can help reduce financial burdens in your finance department? The only data we look at is our local match data. So that's all we need is an increase in our local match, and that will get rid of all our financial burdens. What will it take for FQHC to reimburse via CPE? I believe it was addressed just a few minutes ago. And what are the goals or target numbers to reach locally within the Medicaid jurisdiction? I'm sorry, I'm not following exactly what you're asking for. If someone wants to clarify. Oh, okay, what are the goals or target numbers? So I'm just going to assume you're asking about the local match versus the federal drawdown ratio. So as mentioned yesterday by our director, in order to draw down the full 90 million, we would need somewhere to the tune of $30 million in local match to draw down the full 90 million. I hope that satisfies your question.
Sorry, I want to answer the DOH question. So I know you're asking about a CMS TA to accomplish this. We can email CMS and request information for your behalf. We have done it before, and we did submit information of what type of CPE they would be requiring. And you can also research online because they do have that readily available online on the CMS website.
If there aren't any other questions, I give up the floor and I thank you for your time.
Thank you so much, Finance Acting Division Head, for that lovely presentation and Q&A. And now we are going to take a 2-minute break while we have our panelists for our continuation of the panel discussion yesterday up on a stage. Thank you.
In the meantime, I'd like to call Bev and admin team from Almole. Just a quick icebreaker here before, as we set up the stage for our panel discussion. Thank you.
Well, good morning again, everybody. Are we still awake this morning? Are you ready for our last icebreaker for the summit, for this health summit? Yes or nay? All right. Okay. I promise I won't pick your brains any further than what finance has done to us this morning. That was a very challenging but very fun for us. So if you could kindly look on our screen, we're going to have a little bit of a scavenger hunt this morning just to get to know your table a little more and to enjoy the last day of our summit here today. The first couple of table will win a prize, so we can give out all our prizes today. Are we ready? All right, let's start. Our scavenger hunt today, we're going to look for a pen, a laptop, as stated on our screen here. So whoever wins first, please congregate amongst your table and then find any of these items. Whoever finds all of these items, it's a scavenger hunt. So you can get up off your seats, mingle with the other tables, try to look for our items here, and win a prize. How about that? We'll give you 3 minutes, please. Our time is very limited, so you have 3 minutes. If the time is up, whoever wins the most wins a prize. Thank you. Ruben, are we awake in the back there? Can you play some music while we interact with our scavenger hunt, please? 2 more minutes. After this, our lovely Jen will assist us in our favorite dance because Medicaid loves to dance, and that's part of our wellness check this morning. 2.5 more minutes. The first table to win the most from our scavenger hunt up here will win a prize. One more minute. I see some interaction on this table here. Very awesome. All right. I think our 3 minutes is up. Who's ready to give their list? The winning table? We have one winning table here. Any other table? We need one more table to win this game, please. Winter, can you verify how many items they have? Loud. You can give it to her. You can give it to her. Call out how many items you have won. Table.
Okay.
Okay. Here's another winning table. We'll come to you second. One more table and we're good. All right. So it's 1, 2, 3. 1, 2, 3. Okay, we'll make an exception for DOH.
Testing.
Winter.
Okay, this table came up first. Do we have a pen? Let me see your pen. Let me see your laptop. Let me see your cup. Everybody put up their cup. Okay. Let me see your hat. Oh, okay, we have a hat. Let me see your flower. Does everybody see a flower?
Furry.
I don't see a flower here. Okay. A person wearing all black. Oh, the cameraman.
There's
Mr.
only one
Daniel.
photographer, please.
Oh, I see all black. Okay, something orange. Put it up, put it up. Oh, where's the orange? Orange, okay.
Did we find something furry yet?
No, a bobby pin. A bobby pin.
Bobby pin.
Let me see your bobby pin. Oh, that's an eyelash. Where's your bobby pin? Where's your bobby pin? No bobby pin from that table. Oh, okay. I'm asking that table in the back there. Okay. Now let me see something very furry.
Furry? Michelle's
I see a
table
furry here.
That's not furry.
Where's the furry? Passa amor furry fulfuluai. Se me fulfuluai. Oh no, furry. I only saw a furry here. I only saw a furry here.
Okay, the back table there's got a nice big flower too.
Okay. And then a green leaf. Okay, I see a green leaf. Okay, and the QR code. We have the QR code. Okay, who's the most prettiest in this building?
Let's give yourselves a hand, everybody.
Okay.
All right. Looks like everyone's a winner today, right, Ozzy? Do we have enough prizes to go around?
Everybody's a winner today.
All right.
Good
And
job.
our final wellness for this morning, if we can kindly get up off your seats again, please. Ruben, Jennifer, Miss Jan. All right, let's get up off our seats for our last wellness. This is to stretch our bodies a bit. Come on, everyone. Ruben, go ahead with our music, please. Now, we all know the dance electric slide, right? Yeah. So if you're bold enough, you can come in front here and display and dance for us this morning. Let's hit it, Ruben.
Go to electric slide.
Come on, everyone. This is part of our wellness. Come on, Ruben.
You gotta feel it.
Let's go, girls. Go, DOH.
I see DOH on the ground. Where's DOE?
Go, director.
Where's DOE here?
Only DOH is up in here.
Heavy equipment provider.
Come on, everyone. Last day of our summit. Hi, Mama.
Where's LBJ?
Come on, DOE.
Come on, LBJ. Don't be scared, LBJ. Hey.
Dallas to end our 2025 Health Summit.
Come up with your wheelchair and your cane.
Come, let me take you on a party ride.
Come on, DOH.
And I'll teach you.
I don't see LBJ up in here.
I'll teach you the electric slide.
Are our adrenaline's pumping yet?
It's a mystic, it's electric. Woogie, woogie, woogie.
Get it, ladies.
It's electric. Woogie, woogie, woogie. You can't do without it.
I see Mama with the cane.
Woogie, woogie, woogie.
Got a single man up here.
Don't wanna lose it.
Lunch is almost ready.
Woogie, woogie, woogie. But you can't use it.
Are we warmed up yet?
Woogie, woogie, woogie. But you don't
All right. Let's give yourselves a clap. Thank you, Ruben. Thank you, everyone. And that concludes our icebreakers for this Health Summit 2025 for Medicaid. It's a pleasure to have everyone this morning, especially our day one attendees. Faftai, Malolavar Famalosi. Thank you, Ozzy.
How about a round of applause for our admin team, making sure that we are still here. And now we are going to turn it over to our panel discussion, and that will be facilitated by Madam Director Luisa Quaya.
Testing. Thank you, Aussie. Thank you, Bev and Jen. What a fun icebreaker. We needed that. It's good to move. Keep moving. Okay, hang in there with us. We just have one panel discussion and then lunch, and then we'll conclude our Medicaid Health Summit. I hope you've enjoyed your time here. Have you? We need more of these. We need more of these opportunities to collaborate and to talk about healthcare. Okay. Over the past few days, we've heard heartfelt feedback from beneficiaries, providers, and community members. One message has been clear: we need stronger connections across our health and education systems, better outreach to our people, and a more responsive approach to the unique needs of our communities. Today's panel brings together leaders from across healthcare, education, and human services to reflect on what it truly means to build a system that listens to the people and works for everyone, especially those who often go unheard. Our discussion today is titled From Community Voices to Coordinated Care, and we'll be focusing on how we take what we've heard from the community and turn it into meaningful connected action. Housekeeping rules, again, each panelist will have 2 to 3 minutes to respond to each question. We're going to focus on solutions and practical recommendations. Be respectful of others' times and perspectives, and feel free to build on another panelist's point, but keep comments concise, and then we will end with an audience Q&A. Without further ado, I would like to introduce our panel. A few of you, I don't see you out there, so we are going to improvise. So be ready. You might get called up last minute, okay? But I do see our Medicaid Clinical Director, Dr. Annie Fuavai. Let's hear it for Dr. Annie. As she's making her way up, we've invited Dr. Vaitinasa Salu Hunkin Finau, the former DOE Director and Champion for Education Equity, to join us. Thank you. And then Ms. State Director Tafa Tupuola from the Pacific Center on Human Security. Tafa, please join us. Acting Clinical Director from the Department of Health, Dr. Sipili. Are you out there, Doctor? Yes, please join us. And then, who else do we have? Oh, our executive advisor had to leave. We don't have anyone from LBJ. Is anyone from LBJ here? Just finance? Would anyone like to sit in for LBJ? Okay. Thank you, Falitua. Ms. Savali, please join us on the stand. And then Medicaid crews, please be on standby. Maybe I'll have Tila. Tila, do you want to bring a chair up here, please? Ms. Matilda Cruze, our Medicaid Program Integrity Division Head, will be joining us. Can we get an extra chair, please, for Tila and... She got it right there. Thank you. Okay, Ms. Savali Sunia, she is the dialysis administrator from LBJ, so let's hear it for her. Okay, so I crafted some questions just to build off of yesterday's engagement, but we are going to go through those questions pretty quickly, and I really want to turn time over to you in the audience to ask your questions of this amazing panel. And look, we're all women here up here. Yay! This is in honor of Women's History Month, you know? So this is great seeing our women here as leaders in the healthcare industry. So thank you. Okay, are we ready? Let's see. Okay. Number one, this is probably for LBJ or DOH, but where are the biggest gaps in coordination between healthcare providers and other support systems? And how do these gaps impact patient care? So really, the healthcare providers would be you. The other support systems are Medicaid and other, community organizations that are out there. So where do you think the biggest gaps are in coordination? And I'm going to start with Ms. Savali.
Thank you, Luisa. Thanks, Luisa. So, you hear me? So I know that Dr. Sunia touched on this yesterday. As she indicated, I'm with dialysis. And the gaps that we see in dialysis is the NCD preventive services. We have such an increase in dialysis. We're actually over capacity. And it would really help if in the front line with the preventive care for NCD, and I guess if you look at provider partnership, that would be between us and DOH, to really get out there and avoid the dialysis stage 4 and stage 5 at an early stage.
Thank you. Dr. Sipili, would you like to weigh in? Can we get the mics working, please?
Okay, thank you, Director. Before I get into the question, I just want to mention that Dr. Eminoni is going to get it from me after this forum because he did not tell me that I was going to be here, but I'm sitting up here, but I'm honored, and I'm going to give my best to help out with the forum and answer any questions that we're going to be asked today. Yes, first of all, there is and has always and probably will always be a gap between the service that we deliver and the services that are provided by other agencies. But that gap, of course, needs to be bridged. And we are working very hard to bridge that gap. Public health, of course, is preventive. We can go out there and prevent all or any of the illnesses or diseases or conditions that our population has as far as medical and issues are concerned. But one of the problems that we encounter is the patients do come in to us or even to LBJ at a later stage. And so when they do come in, at that point, it would be kind of difficult for us to do the prevention at that point. So we are still trying and hoping to go out and try to catch the diseases, especially these NCD ones, the diabetes, kidneys, the cardiac cases, earlier on, so we can curb the problem earlier on before it gets to such stage. Sometimes with our population, I'm sure some of you already are aware that regardless of how much we preach prevention, make people aware of these diseases and problems and give them advice, counsel, but some of them do still give us a deaf ear. We cannot force them to change. We can only assist in changing, providing a better well-being of the patients and better health. We don't judge them, we don't blame them. We understand that people make their choice. We only make them aware that prevention starts from them. Prevention starts from the individual, within the family as well. Because it would be difficult for us to try to educate patients when they are not following the advices at home. So we just want to keep advising everyone to please start within your home, your own self. If you can try to change yourself, then we can help you. Like they say, if you cannot help yourself, we cannot help you. But we are here to definitely help you, give you information, make you aware that these are the problems that can happen if you don't do this and do that earlier enough to prevent the problem from getting worse. Because once it gets worse, it'll be LBJ, and sometimes it cannot do much at that point.
Thank you.
Yes, prevention is very important.
Thank you, Dr. Sipili. Anyone else want to weigh in on this question? Yes, Dr. Annie.
Thank you.
Oh, and before you say anything, Dr. Annie, we have an audience via KVZK, so feel free to speak in English or Samoa. It's up to you. We do have an audience listening out there, okay?
I think this question aligns well with what I'm thinking to wrap up our session. Like, where do we go from here? What's next? And as an individual, do I play a part in improving our healthcare situation that we have now? And the answer is yes. You play a vital, major role in making a difference here in American Samoa. Ole tato nga luenga fai faatasi. Apa halu se kapele le kaavale le maluha mai fa. O fala velave mai kero le fai la ula. Sorry.
You can repeat yourself, Dr. Annie. Go ahead.
No, I won't. Thank you.
Okay.
Just trying to break the ice there.
Thank you.
But anyway, those are the questions that we ask, and we do play a major and vital role in making a difference in our community. Please don't underestimate yourself. We have to work together. In each government agencies, we need to build bridges. We need to collaborate with other agencies in order for us to get our data. It's very important we get data because it speaks volume. And it's very important for us to get documentation so that we can see a difference in our community. And by saying that, that will also help DOH, we have the medical director, to improve on their prevention programs. Because as I have stated yesterday, it's very important that we prevent it before they get to LBJ. By the time they get to LBJ, wakuwai. Bawal mela whakalikako, or kawaso, dialysis, pe o le faku, you know, so prevention is very important. And I think it's time for us, let's walk the talk. Wake lea fongkanga kako awai, e ofo I Amerika kako woa, it's the same thing that we hear. This will also improve the LBJ services. If we are able to identify the three top illnesses, such as ophthalmology, o le leanga o tatou fofonga po mata ono le suka toto mawalunga, o le leanga o tatou fatu, leanga fo o tatou fatu maa, ono fa maia nei. We can improve their service. And then lastly, when we have the data and good documentation, then those data can be presented to Medicaid to expand our coverage. Ele mawhainga ngayoi le Medicaid include ia isi mau whaamai. Pe awhape le ai se kako data support ai maave lunga le CMS. So what I'm saying is, we need to do our own part. Wherever you're working, just collaborate, and then we are the last one to get the data and the information. Nga mawaila iyo tato o services here mana o ai peo setasio tina autism. If even me, I always say, oka le alu ilungo o ngu melo o ngai ka meiki po alo fo infanawa al tato atunu o lo mawale nei fa mai o le autism. But nobody has the data. And if they have the data, I don't know why, what they're going to do with it, but I think it's time for us to make a change. Thank you.
Thank you, Dr. Annie. Okay, you want to weigh in?
Yes. Hello, hello.
Yes, it's working.
I'm sitting between two doctors.
You're a doctor too.
Health doctor. I'm not a health doctor. I also like to say that whatever I say here is not towards anyone personally or any department personally. Where are the gaps? The gaps are between our government and the federal government. And I say this from personal experience. On one of my trips to DC to discuss grants for the Department of Education, I made a personal appointment with the head of the grants that we received. And at that moment, when I told her that we submitted a plan, a 5-year plan, she submitted and allowed us ahead of time $2 million right in the spot. The point is, we need to get closer to the federal level. But I don't know about this time with the new national leaders. We need to prepare. Second gap, there's a gap between ASG departments. All of the departments. We're not connecting. There's gap between ASG departments and the community. We're not connecting. Weak transparency, inconsistent level of equality, equity, hit or miss improvements. So the whole idea of the gaps, it exists and we can do something about it. Thank you.
Thank you. We are bridging the gap with this summit, right? We are trying to at least, but thank you. Oh, yes, Tafa.
So, and I'm coming from a disability lens. And so I'm glad special ed is here because it's not when it comes to the children with disability, we tend to be more reactive. And it seems like because they have a disability, everybody needs a wheelchair. And yet, there are times when the children goes to the hospital, there's no medical diagnosis what type of disability they have. So they age, they get older, they exit the school system, and they still have no diagnosis. And they're aging along the way as an adult, still no diagnosis. That's a gap. That tells me we don't have anyone to make a diagnosis when they get into a healthcare facility. That tells me if there's a diagnosis, whether the child has cerebral palsy, autism, then we can understand what better care to provide them throughout the hospital. And at some point, you know, as they age, there's no PT, there's no OT to teach them how to hold a pencil. Imagine that. There's no OT to teach them how to hold a pencil. That throughout the school years, they need a pencil, but no one is showing them how to hold a pencil because we don't have the qualified professionals in town to serve our children. And yet I do hear special ed say all the time they need a PT, they need an OT. The struggle of a Pacific Islander, right? The intersection of being a Pacific Islander, having a disability, and then come from a low-income family. And yet we bring these issues to the table, we talk about it, and it's all about whoever is able to make time to listen, that when we walk away, who's walking away with problem solving? We walk away, we heard what we needed to hear, we go back to our desk and we go back to doing our regular job. No one's solving the problem. So at some point when we talk about gaps, we need to bridge it at the bottom root as possible, get the early intervention that as they age in school, they know how to button their clothes. They learn independent living skills because they're getting these services, these healthcare services in the classroom, at home, when they go to the hospital. That's a major gap. So I understand completely when parents come and they get frustrated. Every space I go to, I hear them, their voice. It's because their problem is not solved. That's another gap. And I'm so grateful for this space. This is the first time we've ever had so many parents and service providers bring up the issue about disability. And it's time we keep it going. I know it's taken 30 plus years to get here, but we got to keep on going. Thank you.
Thank you, Director. I'm really loving all of the comments here. Moving on to the next question. I think we've been talking about this a lot. What systems or processes can Medicaid and DOH or LBJ put in place to better align resources across agencies? I'm going to allow Ms. Tile Cruz to respond.
Thank you. Thank you. Thank you for allowing me to be a part of this prestigious panel. So ways Medicaid can help. As the payer, we're also obligated to enforce some sort of, how can I say, in the Social Security Act, we are required to allow our beneficiaries to have the freedom to seek providers they want to seek. So it is our job as Medicaid to ensure that we try to get all the necessary healthcare services that are needed for our beneficiaries. How could we also help? Well, a lot of it is we can help by informing, providing education to our beneficiaries of what services we offer, what don't we offer, and then also give them some sort, we have to also, our job is also to outreach to our agencies and let them know this is what we do, what can you do and what can you not do, and how can we help you. So it's going to be a lot of outreach on our part, and also, also another thing that we also should take into account of is, one of the things that helps us drive or move any of these, services or things that our beneficiaries need is the beneficiaries also need to let us know. If something's not happening at the provider level, or you're not receiving a certain care or service you're not receiving, you should let the Medicaid agency know so we can investigate and ensure you are getting the services you are entitled to.
Thank you, Tile. Dr. Sipili? let's keep our comments to less than 2 minutes, please.
If something came in mind, and I wish to add on to the comment that was just recently made very well. What I was thinking was we'd like to do public awareness all the time so people are well informed and well educated about problems, assistance programs that are available for them. Some of them are very reluctant to come in and seek advice or want to get information, but to go out and give it out to the community, I believe it would be much, instead of us coming here and sit down and speak the second language that most of the population don't understand. I know all these programs from the federal and the US are in English, but if there is a public awareness outreach through medias, TV, or maybe just go out to the community, collect them at some place in the villages, and explain to them about the benefits and how they can be qualified for these programs, and have it in a Samoan language, I think there would be, this would be much more beneficial to our people. Yeah, that's what I wanted to add. Thank you.
Thank you.
Dr. Annie has given me permission to speak. How can we change the gap? Am I on the right question? How can we change the gap? We need to get the data. We have census data that's been collected every 10 years, and every 5 years they go back and check. We have the data about everything in American Samoa. Why aren't we using it? Need to develop a comprehensive 10-year American Samoa government health care plan based on health care services, needs, based on data, a part of the overall ASG 10-year plan of all ASG departments. I have not heard about a 10-year plan in the last 10 years from the government. I have not heard. Is there one? If there isn't, that's why this gap is getting bigger. We need to look at the data and use it to our benefit. And from the data and the plan, develop clear vision, mission, policies, and procedures to resolve issues and yield better health care services. Data, planning, vision, mission, policies, procedures. Amen.
Got it? Thank you, Dr. Salu. Okay, question 3. From your experience, I think we covered this with Director Tafa speaking about this, but if any of you would like to weigh in, this would be great. From your experience working with students, families, and individuals with disabilities, what does it look like when community voice is truly centered in systems design? We heard the problem, we just haven't really talked about a solution, and I know we don't have the time for all of that now, but anyone want to weigh in on that question?
Hello.
Okay, go ahead, Dr. Salu.
Listen to the community's voices. Change the current come to me healthcare to go to them. I remember, as I shared earlier, I think yesterday, when I was a little child, the nurses would come out to the village periodically to check that every child got their shots, that that was very common in our days. Moo moo. They would come out and check. And by coming out, they knew what was happening in terms of living conditions, the health, everything about the villages and the children. So we need to change that come to me, come to the clinic, to go to them in the village if we want to make a change. We need to utilize the existing cultural organization of the Matais, Pulenu'u, Kingifio, Kingama, Kamaikai, Aumanga, we're not using that. That's already in place. We're not using that. And there's power in there because that's where our people live. And we're not utilizing that. Greater clarity, greater consistency, greater commonality between health services for our people. Every 6 months, go. And don't use that, come to me. Go to them, Faftai.
Thank you, Dr. Salu. And that goes for our clinicians as well. You know, we need to practice what we preach. We can't just tell the beneficiaries what they need to do, because if you're taking care of us, who's taking care of you? So be sure that all of you clinicians out there are putting yourselves first and making sure that you are getting seen. Dr. Annie.
Thank you. I feel sorry for DOH. They have a lot of work to do from this summit. But anyway, I just want to share with you something interesting. When I was working at LBJ, I used to do the fill in the forms for SNAP, American Samoa National Nutrition Assistant Program. And the requirement for that program, I'm sure they're listening, is you had to have a disability. I'm telling you, that is data right there. It's probably 95% of our population are disabled because they're qualified for that program. But what I'm saying is, that really attracts a lot of our people to come and fill in the forms. I mean, ranging from, like, even diabetes, they think that's a disability. That is not a disability. That is NCD, unless you have an amputation of your limb, then you are disabled. But it's just amazing. I just wanted to share that with you. The data I collected at SNAP. Thank you.
Thank you.
I also think that we need to rethink the cost of care for people with disability, especially for those who were born with a disability, because the cost to care for a person with a disability is about 10 times more than a person without. So imagine if you have 2 children with autism in a household and you're the primary caregiver for grandma. Your household income does not really speak the cost of care in your household. Those are inequities. So we need to think as Pacific Islanders, the cost to get a referral, the cost to pay for a caregiver while you're going on your referral, the cost to care for the 2 children with autism, all that behind the scene costs before you get the health care service. This is the life of a Pacific Islander, and we're not talking about those hidden costs. That's the major gap. It's called inequity, although we shouldn't be saying that, but these are major threats to our health security as a family or a household that that takes care of our children. Again, we don't want to put them in an institution. They have a right to live with us. They have a right to live in our community. We need to address these hidden financial costs to basically speak volumes of us as Pacific Islanders. Thank you.
Thank you. Yes, we do need to pay more attention to uncompensated care. There's a lot of that going around here, especially with caregivers that are unpaid. And we are having those conversations now. Thank you. We'll move on. Next question. How can we institutionalize community feedback? Not just during summits like this, but in everyday planning, budgeting, and program design. You know, after today, what is the next step? What are we going to do? What have each of us committed to do to make that change? We have a lot to do. We have a lot to follow up. Our team is going to debrief. But I want us to be thinking about that. What are you going to do to commit to making change after today? Because as we've seen before, people love to talk about it, strategize, come together, come up with ideas, but it's the implementation that we are poor at. It's the execution of these ideas and plans that we are poor at. Anyone want to weigh in on that conversation? Because community feedback, this is how we're supposed to be listening. Where is that being gathered? Who is it falling on? What ears are listening to the community feedback? And if there aren't any ears listening, then we continue to perpetuate the issues that we have, correct? Okay. Let's go with one more, and then we'll open it to the floor. What are we doing or not doing to reach families in underserved villages with limited access to care, information, or education? I feel like this question came up yesterday, but let's reiterate if we can. Dr. Sipili.
Yeah, I just want to add to that question. We all understand and aware that our aim and goal in healthcare is to improve the quality of life, maybe prolong and promote care, give the best we can to improve the health of our people and our population. But we also are aware that within our island there is inequities and social determinants of health that is in the way or not addressed, which is something that we really need to look into and take it seriously, because we like to treat everybody the same. Everybody should be getting the same health care in this island. There is no discrimination of who's old, who's young, who's a female, who's a male, who's Palangi, who's Indian, whose family is this, whether they're healthy or not healthy, but our aim is to focus on those who are unable to provide for proper health care. So my point is, we would like to, I know our people would like to have specialists down here, and as you heard yesterday from Sunia, they have tried to recruit some of the people from our island, but the problem is the pay may not fit them. They don't want to leave their comfortable and families out there to come here. They may have not heard of American Samoa. Excuse me. So what I'm thinking, because we do have a lot of stroke patients, as well as some of the disabled children and even adults. And I believe we don't fully have that service available for rehab. You know, things like occupational therapy, physical therapy, getting back to a new normal life. It may not be a completely normal life, taking into consideration how serious their condition had been, but at least getting them back to a new normal life in society. So to look in those areas of utmost need, I think that's where we need to focus at. We need to identify what is really needed here as far as health service is concerned. I believe from hearing one of the mom yesterday with her autism kid, and even some of the other mom parents, I think we need to focus into that to try to get a specialist or some specialists that are really needed for problems that are common here in our territory, so that, you know, the medical issues are addressed and that they get the help that they need, the appropriate, because we all do know that most of our healthcare providers are capable, but they are not specialists. We don't have that many specialists here on island, so we need to at least look into that. Thank you.
Thank you for that. I think it's important for us to remember that we do have limited resources, and with limited resources, it's really hard to reach the people that need the most care. And having conversations like this, people starting to get ideas of how they can then reach out to the community is important, and collaborating with our education team. There's so many things that we can do that we should be doing after this, okay? Did you have something to say?
Yes. Thank you, Director Quah. So to segue from number 4 and somewhat 5, I really would hope, and thank you for the summit, hope that we can take away from here collaboratively between all the providers is to not hit the government, but approach the government, because this is really a community and a whole. It's not just DOH's job or goal, but it's for everyone. But it needs to come from the government level to agriculture, as Dr. Sunia alluded to yesterday, to getting out to the villages, Samoan affairs. And take, for instance, we keep talking about NCDs, but the kids will go to the store and buy soda because it costs less than a bottle of Vaimalu, and bongos cost less than a thing of fruits. So it needs to be a well-rounded effort between all the government agencies, DOE, and educating the kids and identifying the disabilities and what have you, all the way to the hospital bed. So I think if we can take from here to the administration, how we can collaboratively attack this problem. It won't be just DOH or LBJ or DOE. It has to be all the other entities that bind together to make this happen.
I absolutely agree with you, Administrator. I know that with the new administration, lots of changes are happening, a lot of questions as to their organization. But our executive advisor over health and human services, she was here earlier, she's been here the past 3 days. Her role as the executive advisor is to bring together all of the key stakeholders in the health ecosystem and to allow support and to bring information, make it flow more freely between the departments as well as the governor's office. And she has organized the key stakeholders in the health department, meaning the CEO of LBJ, the director of DOH, the director of Medicaid, the director of DHSS. All of these key stakeholders were brought into a room a few weeks ago for us to establish a health council. And this health council is going to help create the strategy or plan that Dr. Vaitina Sao was referring to earlier. But I just want you to know that there are things happening, right now, and things are fairly new, but we are seeing how working in silos does not help us. We need to collaborate and work with each other to get things done. Okay, so I'm going to skip to our last final question, our vision forward question, and this is for each of you. If we could make one change tomorrow that would improve coordination and equity across the healthcare and human services system in American Samoa, what would it be? I'm going to give each of you a minute to start and respond to that question. Shall we start at the end over there, Dr. Annie? If we could make one change tomorrow that would improve coordination and equity across all the healthcare and human services system in American Samoa, what would it be? One change.
Come to the table and collaborate. Thank you.
Thank you.
Use the data and plan vision, mission, policies, and procedures.
One change that I personally would add on to this council of stakeholders, as Director had mentioned, is to maybe, including the government, if they can enact a law forbidding some of these fat food that come into our island. If Western Samoa was able to do it over some time with Mamue and Muripipi, kulole malu malpair fa fong or kako fa pokopkongan ngiyas, why can't we do it? Or because we can only preach, don't eat this, don't eat that, but if it's available, then people, and cheap, then people will still go get it. So maybe start with one. I don't want to take off all of what you guys want to eat, but at least start with something. So if maybe something like that, no more bongos and stuff like that. So yeah, that's what I would probably do. Thank you.
Thank you, Dr. Sipili.
It would be to solve the $30 million match.
Ooh, that's a good change.
Testing. For me, it'll be accessibility. So making healthcare accessible for all our beneficiaries.
Awesome.
And last, I think if we partnership between all of us can really bring an effective change.
I love it. Okay. Now we're going to turn the time over to you. We'll take a few questions because our lunch is ready. Okay. So anyone out there would like to ask a question today, please keep it focused on solutions. No questions? These ladies answered everything? Are you awake? Raise your hand. Are you awake out there?
Director, Dr. Anesi said it's on the online, the questions.
Oh, okay. I don't have access.
Nino?
Can someone pull up the online questions?
Sorry, I do have one question, and I asked it before, and Matilda answered about the FMAP at 100%. I understand about the tribal eligibility, but why are we still not trying to advocate for 100% match? Because if we're also talking kind of about indigenous populations similar to AI, American Indian, Alaska Native, even Native Hawaiians. So is this, I don't know if this is the forum to even bring this up, or should we be talking about that, or?
Yes, we should be talking about it. Like Matila said, it is an act of Congress, so we should be directing a lot of these questions and concerns as constituents to our representative. This does play into being establishing a key designation for our people, but we can also look at other ways of pursuing 100% FMAP. Usually that comes with emergencies, but I think in this instance, we are in a crisis. I do feel that. And we can leverage what's happening here with our healthcare system to pursue those conversations, because it would have to take some legislation to change that.
I do want to add, we did try. We went to on the Hill, we advocated, and what was recommended to us by the Hill was the easiest low-hanging fruit you can do right now is at least get 83%. So it's something that we'll have to, work on and work with our congresswoman to get that happening.
We do have a relationship with our legal team, counsel team, now with our AG's office as well as the legal counsel, so we can definitely have those conversations. Hi.
Hi, my name is Ipu. I serve under public health, serving women and children. I usually ask questions about disability because that is my area of expertise. But this morning, I want to pose a question to the panel and anybody in the room about lifestyle medicine, because there was a heavy conversation about preventive approaches and, emphasizing prevention. We just came from Hawaii, where we visited one of their health centers, and in this health center, they have implemented exercise groups as part of their their care services. They also have included plant or traditional medicine practices as part of what their healthcare centers provide, as well as lifestyle medicine that doctors can prescribe, going to eat more vegetables instead of giving you prescription for a medication, and doing more exercises. So to envision American Samoa going towards that path of more preventive approaches using lifestyle medicine, do you see that in the future of American Samoa's healthcare? And is that something that Medicaid can also kind of think about, using lifestyle medicine as an approach to addressing the heavy non-communicable disease burden that we have continuously in this environment?
Thank you for the question. I will volunteer to answer that one or share into that question. Yes, we had discussed that during some of our medical staff meetings about incorporating the natural herbs, natural medicine that we have available on island to traditional medicine. When we talk about something, we need to plan and implement something. So one of the things that we're thinking of is to erupt a small, like a little drugstore there at Tafuna, where we can sell the herbs medicine, the vitamins, the plant-based supplements, things like that, if patients opt to try those for better health. We do, of course, preach to use vitamins and minerals and all that. So we're gonna have those available over there for people who would like to purchase those, because we understand that most of the medications, traditional medicine all over the world are, of course, some are plant-based. They're produced and manufactured out of plants. So never know. It's just like here in our local community here in most of the islands, in the Pacific Islands, we tend to resort to bush medicine using, traditional, not traditional, the herbs and the traditional massage and traditional medications using plants that we have growing here on island to substitute for some medicine if they cannot afford, or if they think that it works better than traditional medicine. Yes, we're all for it, so long as nobody gets poisoned from it, or overdosed from it, or something happens to them from these practice that they do out in the community. I know most of these medications, there's no scientific studies into them, whether they're actually effective for the purpose that they're using them for. But generally speaking, we had not come across anybody who had much problem with these common practice of practicing medicine that is out of the traditional ways. So yeah, so long as there's no serious problem, yeah, we're all for it, and we are advocating the use of on-the-counter vitamins and minerals and things like that out here in the Tafuna Health Center in the near future.
Thank you, Dr. Sipili.
I just want to ask, I'm going to look at it from the lens as the payer and the compliance. In order for us to cover these sort of naturopathic services that you're wanting, there needs to be some sort of foundation of regulatory compliance that's done at the local, like, regulatory. So there needs to be some laws and rules in place to protect our beneficiaries. Say, for instance, they get just a really bad fufu that actually exacerbated their condition. There needs to be some standards in place. And second, Dr. Sipili did mention, there's not enough scientific data to show that these naturopathic alternatives are good. I do think it is a good alternative, but until we have the groundwork, where we're talking not only with just Medicaid and DOH, but even our FONO members, our governor, to advocate for these services, it's gonna take a lot of work.
It also we need to do some trials, there has to be some research done. I know that there are a lot of groups that would be willing to come out, do some research regarding whether or not, natural remedies are effective, and we just don't do that much here. We don't do it. We don't host trials or clinical trials here locally, and those are things that we can talk about. But I think if it's in the formulary of LBJ or DOH, that's something that they would be able to then hopefully, claim. But you still have to work with our team, like Tile was saying, to make sure that the services are written into the state plan, which I don't believe they are at this time. But it just takes all of us working together to figure it out. I would love to see the outcomes of that health clinic that you attended too. Hopefully you can share what you've learned. I mean, this is all about best practices, and we are all for expanding and strengthening our relationships with Hawaii's healthcare system, because that is the alternative for us when we don't have the services here. So, thank you.
Mga facility for traditional healers. Thinking back, wale nga recognize Samoa ia le mele ta o le traditional healers. Pe o le au whako sanga. Onga ngā kaimi ia kau le inka vale ka ngaka ia e lava ka ngaka I kongol mu e whaiel maka whaioi lea se iwa kulo o le whawhangau o whawhinge. Ia o asonge ia wakele ka vale, and we have easily accessible to our health centers. Wakaule yaise se need for imo kako whako sanga. But for olo o yai pea traditional healers in terms of fofo, unfortunately, wokokongi, ay mga o massage, yang ay alula ia le fale Filipino po Vietnamese e fai elo fofo, but those are all part of traditional healers. But one of the points I want to stress at this summit, there's a danger to that. Mele ole kangakalale maisuka. That's why we have a lot of people ending up with amputations of the limbs. E mumusu e kuile insulin, mumusu e ingufala au olo I traditional healers ia fai fofo. Ia e tinga lava na tilo atu e leo ia se swinga au lo fai pea pai Samoa. So next thing you know, wa maile mai wa tinga aina ele ngata wa tatau ona tipile ona ta otoi I vai ya ai wo o tulanga wa ni le dialysis. So there's good and there's bad into these traditional healers, but there is room. I must say that the World Health Organization recognizes the traditional healers, particularly in the island nations. Island nations here, like Papua New Guinea, Fiji, that they have less accessible to the health centers because of the tele o le atunu. Unfortunately, the USA are not part of WHO, as you all know. Kipi e Trump le meanga. So I don't know if we're recognize traditional healers. But anyway, yeah, that's the downfall of meange o fofo. Fa mole alu mo fan ma isiaki po se ma e tatau ona fofo ia ona nga idea ile fofo fa Samoa mlo fa alu lava fa tai.
Thank you. Any other questions out there? Okay, I think we have a few questions here on the board. Number one, is care coordination services critical in improving compliance and utilization of services? And how do you plan to improve this in your individual sector? Is care coordination services critical in improving compliance and utilization of services? And how do you plan to improve this in your individual sector?
I think that question should be directed to LBJ to improve the compliance and the utilization of their services, because they are the healthcare providers that are providing a lot of services to our people. Thank you.
I think it is critical. Coordination of any care services is critical. Whether or not it's critical to compliance, that's another question, but we all should be in our operations, in our standard operations of procedures, protocol, we should be very mindful of coordinating these services and care services for the patient.
I just want to add that, again, we all want the best care for our people, and we all would like to get all the medications, all the treatments, all the therapies available to us. Unfortunately, we also all know that with not enough funding, we cannot get the full service that we all would like to get. But we do coordinate with LBJ to, as far as patients that do come in. If of course they're sick patients, we send them over there. If it's patients that we feel we can treat, then we keep them. But it's not just LBJ that we coordinate with other agencies that we feel can help us in some ways. For example, Helping Hand is coming in to help us with some disabilities, and we do now have a pediatrician at the DOH who is going to be looking into helping these children with disabilities. So that's an example of a coordinating effort that we are working on with DOH. Thank you.
Thank you.
Hi, Tess. Hi, my name is Dr. Salo Filetiti, and I'm the Vice Chief of Staff for LBJ. Sorry I was late. Anyways, going back to the discussion, the issue that was brought on, the coordination. At LBJ alone, we have social workers who, when patients present to doctors, and of course, most of them cannot afford, especially our non-resident patients. And sad to say, these are the patients, most of them, these are the ones that are chronic. So what LBJ does, we have our social workers who discuss with them, who meet with them, and try to work out a plan so they can afford these medications, and especially with helping them attend to their follow-ups when they're scheduled to see their primary care physicians. That's all I wanted to add on to that issue. Thank you.
Thank you, doctor. Appreciate that. We should have you on the next panel. Okay, next question is, who is willing to cost share? Oh, someone's bold here. Who is willing to cost share to bring school psychologists willing to screen and diagnose our kids for autism? Who's willing to cost share to bring a psychologist here?
So I've been seeing home community-based services for the past 3 days. I did present on Monday about the services under HCBS. Under HCBS, the 1915C waiver is an education section. CMS has pushed out several funding opportunities called SBS, school-based services, Medicaid school-based services. So this is a local issue. What I realize that people see when it comes to children with disability or special education, they see everybody as teachers. So if you're a PT doing the service in the classroom, you're a teacher. If you're trying to do OT speech, you're still a teacher. You get paid as a teacher. We all know teachers don't make good money. That's another gap, right? Nobody wants to work to do healthcare service, which is a school psychologist, to get paid teacher salary. Another gap. So the question would be, does human resources have classification in a school setting to recognize healthcare professionals and get paid healthcare salary? That's another gap. This goes right back to trying to bridge the gap with care. It wasn't just about the wheelchairs. It was the fact that when the child is born, they're released. It's only when they have a physical appearance do they get noted in the, that they have a disability. But no one's catching the hidden disability, such as autism. And so the child released from the hospital, they go home, they get cared, no one's talking to WIC, right? Because the child doesn't have a physical appearance. Everyone thinks that having a disability, you have to look a certain way. And then years go by, they may not opt into early intervention, which I highly recommend. That as they get older, they start to realize this child is experiencing delay, another healthcare issue. They go into the school system. No one can do an educational diagnosis because there's no medical diagnosis. No medical diagnosis, nothing's wrong with the child just has a learning disability. Child does not have a learning disability. He has another disability. So these are systemic issues, and I can't understand why it's taking my 34 plus years of working in this space, why we're not addressing the issue. We're really not addressing it. We're only putting the Band-Aid. So when it comes to children with disability, know that they're exiting a system into adulthood, can't get a job because we haven't provided a proper diagnosis to give them the proper services, give them the proper health care, that they're ready to go to college and they're ready to get a job. But they're at home waiting for someone to take care of them, which is another health care service. So pardon me when I get emotional. I always get emotional when I talk about this because we need to address the root of the problem. It's a threat to our health. It's a threat to our children. It's a threat to our parents and our grandparents. We need to address it. Thank you.
Thank you, Director Tavat. It's okay to be emotional. That's how we get things done. But are you going to cost share? Or who's going to cost share and bring the psychologist down?
I'll be at the table and we can figure it out.
We will talk about it. Yes.
Yeah, for Medicaid, if you're talking it in the lens of Medicaid, yes, there is an entire benefit called school-based services, but in order for us to even to do school-based services, what facilities do you have in place that are certified, that meet the standards to even offer these services? Do you have some sort of school nurse located at the Tafuna High School or the school? Is there like a designated nurse room where they can go to receive these services? Is there a place for the school psychologist to offer these services? So there's a lot of things that we also all need to come to the table and make sure, and we should stop talking about this and actually sit down very soon on this matter.
Thank you. Is home visit and outreach covered in the state plan, Tile?
Right now, are you talking about home visit in terms of caregiver, like the nurses come to your homes? Yeah, I know DOH does home visits, but in terms of outreach, we do not cover if it's for the providers, but we can do our own outreach to let you know what services are available for you.
And we are working with the Director Tafaz group to bring about home care-based services. We are having those conversations, and that's a good thing, okay? No other territory has HCBS right now, and we could be the first.
Hi, Director. The reason why I asked, because I keep hearing DOH needs to do more outreach and home visit. Well, our providers are also required to stay within the state plan and also the CHC or FQHC scope of work. So is there an opportunity for us to improve or edit the state plan so they can go out and also, use those as encounters, because they can see a whole lot and get a lot of encounters from school-based visit, right? I mean, MCH does that all the time. So is there an opportunity to revise the state plan to allow our physicians to go out?
Yes, there is, but secondly, we need the funding for it because there is a federal requirement on Medicaid side, which is called the electronic visit verification system. So we are required anytime any service is rendered to a beneficiary, they need to have a way to check in and send us the information that, yes, I'm here serving this patient. So if we don't have that system, and we could offer it now, but there is a timeline that the federal government gives us that requires us to have this system in place. And when we don't have this system in place, it'll cost us more money, and the system is very costly. It's in the tens of millions.
So yes, we can, but there are some steps that need to take place in order for us to do that. That's a good question.
I have a question for Anaise. When you talk about outreach, what is your outreach?
So an example would be providing heart screenings for RHD kids at schools. So I feel like when cardiologists come from Off Island and we go with them, what we do is we coordinate all of the logistics with DOE, and then we make sure that there are schools that are available, that there's space available for us to conduct these school screenings. And so we don't usually get a provider from CA or FQAC to come with us because that's what we're told, is that it's not within their scope of work. So it's not usually utilized as some sort of encounter when we go out to schools. So that's what I'm asking, is there an opportunity to do that? Because I feel like their presence has a better transition from, from the cardiologist diagnosis into the physicians going back into the office or the clinic and enter all of that information into CareView. Like, it just takes time. So some of these kids that are diagnosed by a cardiologist, they don't get to see and receive care until months after because we don't have that transition of, having that diagnosis, inputting into CareView, and then getting their Bicillin going.
The reason why I'm asking that question, I'm glad that the medical director is here. This is not about changing the state plan or getting more funds. But I think one of the goals of this summit is for us to work together, not only with the interagencies, but within the department. So I would like to suggest that when you go out to do your outreach, because particularly for the heart, for the children, take the immunization as well, because you cannot just go on your own without taking all the other appropriate services in your department that deals with children. And so there's a lot of, I don't know what the word is, you guys divide it into compartments instead of working as a team, and that will help our community, help the schools in one go. So you go and check the heart, check the immunization, take a dentist to check the teeth, and help reach out to LBJ to take them to screen the eyes for the kids. And in that way, I think that will be more efficient and more effective in helping our children and our community, but nothing to do with the state plan. Thank you.
I think that's a great...
It's called internal transparency and external transparency. We don't have that. That is one of the biggest gaps we still have. We're trying to work in order to do the service, the best services that we have. And the way to do it is come to the table. Come to the table, invite people that should be there, and discuss how to deal with the issue.
I think that's also a great idea. Dr. Annie provided this comprehensive approach. And it sounds like maybe a healthcare in the schools to do all of that. This particular program she's speaking to is actually customized for rheumatic heart disease patients in terms of screening And I know the funding comes from a different pot in terms of bringing sonographers, cardiologists, all of them here to serve and screen the children in the schools. It's a partnership with DOE. And so I understand what you're saying. Does that count as an encounter? And I think we should reevaluate all the programs that are out there right now to see how we can make them more effective and also get them funded correctly. Because we might be missing dollars there in terms of in-kind care, in terms of impacting our local match. There's a lot of things that we can, I think, be creative about, and just, if we can't articulate those needs to our federal partners, then it's very difficult. So these platforms are very needed, okay? So.
Can I just say,
okay.
it'll be, I think that sounds like that's something good for the task force to do, a survey of basically all the healthcare related grants and what they actually cover and what they don't cover. Because I think that's what we're missing right now, this gap that we're talking about. We need a needs assessment to show, okay, if Medicaid covers this, what are they not covering? And maybe it turns out DOH is already covering it through another grant. I think we need to do some sort of needs assessment, provider assessment as soon as possible.
Thank you. Okay. Oh, we have another question?
Hi, I'm not sure if it's a question, but I wanted to answer or make a comment on some of the questions up there. To me, I have a very Samoan brain, and to hear all of you, and then I am Samoan right here, there's a big gap right there. And me not understanding, so that means that you need to come to where we are at and speak Samoan to us, so in that way we can understand everything that you are saying. For example, I look at equity, health equity. Oh, what does that mean? First thing that comes to my mind is money, like, oh, my mortgage. And then there is health equity. And to have you explain all that to us, then we can go out and explain to our families, our co-workers, our church people, and that there is also a big gap right there. There are a lot of families inside towards going this way, Leone going back way, that a lot of people don't reach. A lot of those families do not come out. Moms that have autistic children, moms that their children are close to being diabetic, are not being reached. And they do not want to come out because they don't understand what you are all saying. And that is a big gap among all of us. Not all of us are English speaking, but it would be so nice, it's so good to have me understand everything that is going on. And in order for us to reach all those people, the fastest way, church. We have the Whaiwheaus, Whesosoanis, that go and visit their church people, and they know all the back roads, and all the families are back there. The families that are on WIC program, those are the families that we need to reach. There's all those questions like psychologists, how can we get them all in here? All the agencies have their own. For example, SPED, yes, they can get access to all that, but us needing to reach our people out there, that is a big job, and we have to do it. We have to explain to those parents, your children are qualified for Medicaid. Don't go finding all the fofos when you know they're not helping. You're feverish. Every day they're sick. They are qualified for Medicaid. So we need to take that word out to all of them. Forget about our age group. I don't know what we're going to learn about obesity anymore. We still eat what we want to eat. continue on living the life that we've been living. But our children, we need to focus on them and let them know that they are qualified for Medicaid. And that's all I want to say today. This has been a great summit. Thank you.
Thank you, Honorable Fasoa. Thank you so much. Yes, Dr. Sipili.
I'm sorry. Faf tai mo le faf siri tina e mo lea saunoanga. E pefono o kanoa tu le te mi mawai. E o le lawe tau mawhai le Department of DOH e o atu I tua. E peona e saunoa mai. Whaingatai tangata o no mai. So o le singa ma ko go lea e mi ai. O le go out. There is a limitation to what DOH can do with healthcare out in the community, especially pefapeo o mawatu tangata o maitele. Ya o nga refer mai lea a o tene fo mai tu e siaki a inga ma faila to singa. Ba ai mo mua la to po se mai tau o nga tau mai ama to via fo mai tono clinics. Pe sa o fo I amoli o la to mea ngai fai I o e asiasi a inga a ese la ko fesili po se me fielo e la to ya on kolo mai la ia o fai atu ia a o se ngase o mana o mia se ia ma to we o atu tu e fale ya let me know because em fai on o wal watu tua o lesi na mea leo te tau mawhai ne ia I le DOH talu on o sau I tutono le department lea wa sa o masani o ne wa I used to see witness in the past e fai mo meo polokalama foi e TV ia wale koe fai foi e tala noa atu I le tato atu nuu tala noa atu I le ngase ma le ngase me pi fatasi le vai aso se me fa pena o fai atu iai to e fai tato mea na to e fa ola tato polokalama na ia fa malama atu tangata Ingilisi ma tangata Samoa e fa Samoa la vale si tangata ia malama le atunu e le sa o ngai tau te o e fa palangi ma tato fa Ingilisi le o malama mai to te lo le atunu so le singa ma to mele la fai nei o le si mele o te ta o atu nei nge me o va vela o la fai atu o le la aien ma to va ale la o mai e fai ele fe so ta inga male healthcare delivery I le vao o le faitulai o maunu ia mamanu a foi so ai nisi o nu mamanu o ia o le singa service le o la available soon o le ai le vai fa ngo fie foi o nga kili vatu le ke I motu ia sa fa ngata ma lo fa alo lava fa tai
lava. Thank you so much. You know what? I think it's a good time for us to conclude our services here today. You all have been wonderful. If you would just bear with me, I have prepared some closing remarks, and then we will have our closing prayer, and we will have lunch, okay? Is that all right? Okay. So as we close out this historic first Medicaid Health Summit in American Samoa, I want to take a moment to recognize what this event and gathering has meant. Not just for us as the Medicaid staff, but for our partners across healthcare, government, and community. Over the past 3 days, we've shared ideas, voiced challenges, and sparked new energy for the future of healthcare access in our territory. We brought people together from across agencies, sectors, and villages because Medicaid doesn't operate in a silo. It lives and breathes through the people we serve and the partnerships we build. I'd also like to take a moment to acknowledge those who came before me. Since 1983, only 2 directors have led this program. That legacy is not lost on me. Each played a role in shaping what exists today, and I want to especially recognize the directors before me who built the structure we now stand on. the late director Niuatua Andy Pulitasi, and former director Sandra King Young. While we may lead differently, I honor the work they've done to grow the Medicaid program and to create a platform for expansion. To my staff, thank you for your dedication. To our panelists and speakers, thank you for sharing your insight and time. To our community partners, thank you for walking with us. And to the people of American Samoa, we see you and we are committed to doing this work on your behalf every day. This summit is just the beginning. Now the real work continues, building a healthier, more equitable system of care for our people. Whawhitai tele lava. Thank you, students, for sitting through this. I know sometimes it could be really difficult to listen through this, but this is your future. We're really trying to build a future that you can live in and be proud of. So thank you for coming. And whawhitai lava to all of you. I'm not going to apologize for the emotions. We are all emotional people and humans, so thank you for your time. I hope you have enjoyed the last 3 days with us. We have done so with you. We are going to continue this conversation and build the momentum moving forward. We are planning to do monthly press conferences so that we can be transparent and share with you what we're doing on a regular basis. And those monthly press conferences will be in partnership with each of you. So if you would like to participate in communicating to the public, please join with us. We would be more than glad to have you. Okay, thank you very much and have a wonderful day. Whawhitai lava.
Chelsea. Ona a o saunia se tsalo mo tsato tsa mafutanga ya matapunia lo ya ido tsato fa mo mo le yaso. Let us pray. And if I see Tiana nga fa fitai ma vivi if I ya o mato loto mo mato nganga ile nei tu waso le di ido mato tua. Awa lewo mato tau no manuia mai ile si uia le nei fa mo mo sa mato tu ina tu talo sanga ina ia lo fangia de fa mo mo le Medicaid ia ina nga ta idea o pa anga o matanga wenga ta itasi ina nga du lava so tau au awa se manuia o America Samoa a toa le ia mato watua e de ngata I nei na mato ngadwenga ai mato te tano ia avea le nei summit ma le nei fa atasinga ma mafutanga ia se amatanga mo nisi po kalami tele lumanai mato te tano ia ilo fa manuianga ita ia nei a tunu ita ia malo o pisinisi ma company SS mai se fo ia ita ia tsana le ia ilo fa manuianga ia te mato malava I nei yaso a mato tu uale me nei manga ia tu ai ngo fa tali mai pui la wa fio ia la umole a wia e si la fio na sa uni fo ilo fa na wa tsadia 14 wa sa unia mo I mato ia mato ai ma de fa cheche tali ina fo I mane nga fa ftai ma mana tu ai pe de tong yo lo mo e sa unia mo I mato na mato tsano oni se Manianga sana le ato fo I mato o lau whanau. Mato te la fua I atu I lau fio e ato ai mato. Maui ma ngalo I o mato se o malava. O nā mato tano o mato wofo I na atu whaatasi matalo le loto mana ngangor tangata lava ia. Whai e pia lau lava fina ngano. Ai awa lava o mato loto. O na lo lava swafa Yesu o mato wolim wala awa tu ai. Amen. grab and go, feel free to utilize our auditorium.